Hi everyone. Let me know if you can hear me okay. We're here to talk about an interesting company called Cassava. It's a interesting situation. It's a company trying to develop a phase 3 clinical trial, or doing 2 phase 3 clinical trials of a drug they call Cemifalam. And I will tell you why Cemifalam does not work. And these trials will fail. The stock will drop. It's their only asset, so the stock will probably drop at some point down 99%, I think. Day one, maybe not, but it'll probably drop at least 50% when the news is announced, and then probably closer to 99% over time, since the company doesn't have any other products, and it's all a big bet on red, which they never should have made in the first place, because it's a very faulty, poorly designed, kind of like poorly executed plan. But I'm trying to find anybody who's like, I guess not a coward, who can debate this and talk about it and not get scared and run away. I don't know. Maybe testosterone is in short supply these days, but some of you have to have some amount of courage. I know I can be very intimidating. So I promise that I won't make fun of you. Try to be as Socratic as possible and as fair as possible. I don't try to tear anybody down on purpose. I don't make any ad hominems. I just do what I do. I've been around medicine a long time. If you know anybody on Wall Street, you can ask them about Martin Shkreli and his binary event predicting prowess. I've done a pretty good job at these over the years. I've exposed a lot of scams. And, that's what this is. So, I don't know, let's see. Alejo or Alejo, do you want to talk about Cassava? Or it doesn't sound like it? Yeah, he's gone. So anyway, this story kind of starts, and if somebody wants to talk about it. Chris, I don't know, do you want to debate me about Cassava? I don't think you do. Would love to talk to Along, but in the meantime, I can sort of bloviate about the situation. It's a very funny one. It starts 20 years ago when, and you could just signal with your thumbs up or thumbs down if you want to debate me. I don't think you do, but that's up to you. So this sort of starts off 20-something years ago. I'm about 21 years old. I'm working for a hedge fund, and the big boss of the fund, was college roommates with a guy named Remy Barbier. And Remy was basically a biotech entrepreneur. He had a company called Pain Therapeutics, and my boss owned a ton of this stock. And I decided I would kind of look at it and try to study it with him. And so, they went to Oberlin College together, and they're friends, and it's a cool story. And I met Remy. I liked him a lot. Most of the biotech industry did not. But I liked him. He's a perfectly fine guy. I even would consider him back then a friend. And, obviously he was very close with my boss, but, they were college roommates. But, so I liked him, and I tried to sort of look at the positive side of his drugs. He had 3 drugs based around naltrexone and OxyContin, and none of them worked out. So they all kind of struck out and missed, and the whole thing kind of fell apart. And then the company kind of retools, but in hindsight, it actually wasn't much of a retool. And I'll tell you that story in a minute. And this is one of the most fascinating sort of biopharma situations I've ever seen. Kuke Flores, I will happily interrupt this story if you wanted to debate Cassava as a bull. So if you press thumbs up or thumbs down, let me know and I'll add you up if you want to debate this. But anyway, so they pivot into this drug Cemifalam for Alzheimer's disease. And they start this like sort of process of extreme dishonesty that kind of wasn't there before. So it's sort of like something breaks in Cassava and maybe even in Remy. And I don't know if it's his marriage to Lindsay Burns or what, but everything kind of changes. And the company just starts this 10, 15-year period of deceit. And that starts with this drug Cemifalam, which is created by a chemist, not a chemist actually. He's actually profoundly not a chemist. He's a biochemical researcher named Dr. Wang, and Dr. Wang ends up getting arrested. He got arrested, I think, earlier this year, and never a good sign. And he's been accused of faking Western blot data, amongst other things. And it's really not an accusation at this point. I mean, there's very, very clear evidence that he just completely made up Western blot images using something like Photoshop or some other, image editor. And you can actually see that he just simply rotated the image 180 degrees and expanded it and pasted it as if it was some kind of original image. It was really insane. I mean, this has happened before, by the way. There have been many not biotech, but many preclinical researchers that have faked Western blots, and there's just been this explosion of people who have been outed as, oh, you faked this research or whatever. So it's not that unusual or uncommon, but it's certainly alarming. And the guy basically fell in love, it's hard to say anything else, with this protein called filament A. And filament A is a weird protein. Not a lot has been published about it. It's really not an important or interesting protein in any way. But he basically decided that several things. He sort of decided that naltrexone, which is a famous opioid related drug, binds to filament A. Now, filament A doesn't really have any canonical binding sites. It's not really an enzyme. So there's not really a pocket that you would naturally as a medicinal chemist define as a binding site where you felt comfortable okay, this is where the ligand goes, this is what happens to the ligand, this conformation results in some downstream signal, or if it's an enzyme, this is the, substrate that gets cleaved or whatever. And this is sort of not what this protein is. And it's very hard to sort of drug structural proteins. In fact, if I would encourage you to make a list of the last, 3 or 4 years of drugs approved, there's probably 200 or so. None of them would work that way, right? Nobody does that. It's usually you're making an inhibitor to a GPCR or, something like that. And even if you go back to the era before gene therapies and antibodies, most drugs, nobody really made drugs that have this weird structural alteration. The only thing that kind of comes to mind is myosin activators and stuff like that. But it's really intense, deep chemistry. And the weird thing about this company is they've never published any chemistry. And in fact, Dr. Wang is not a chemist. So I looked around and tried to figure out who did the chemistry of this stuff. Chemistry work in drug discovery is very, it's very important. And chemists aren't that expensive. And you can easily hire a team of 5 or 10 qualified people, whether they're in the industry or you can get Wuji or some other outsourced company to do it. It's not too hard to get that and to publish it. And it's really not hard to get a nice publication in JMedChem or any other place. The only time these guys ever publish anything is in the patent office. So they've never done any SAR chemistry that was actually real. And when you look at the patent, none of the employees did the chemistry. They had 2 outsourced guys, which again isn't crazy, but it's weird. And no publication ever about how did they decide this was the molecule. Because when you decide this is the molecule, typically the way I've done it is you want a co-crystal or you want some other structural biology information. So co-crystal is what it sounds like. You have the drug bound in some kind of conformation with the protein. And you take a, snapshot of it. It's almost like a camera. And you can do that by shooting x-rays at it. And using x-ray diffraction, you can kind of get a sense for, okay, this is how this drug is actually interacting with this protein. If you're not doing a crystal structure, you're really just guessing. There's no chemistry campaign that I'm familiar with where you just try to do SAR blindly. You always want a crystal structure. So without a crystal structure, I would venture to say that there is no binding. I actually took the AlphaFold PDB. So the PDB is a protein database. It's the place where everyone deposits their crystal structure information. Not every drug company deposits all their crystal structures, but there are enough filament crystal structures for partial crystallography of the protein. It's a very big protein. In fact, I don't think it'd be possible to even crystallize all of it. But AlphaFold, remarkably, it's by the way something I don't fully trust, but AlphaFold looks almost exactly like the crystal structure that was physically taken by X-ray crystallographers. So you have some parity there where you can sort of trust that, wow, okay, this is the right crystal structure. So I took that crystal structure and I looked at the alleged pentapeptide site. It's not even something not a phrase I would use. But again, Wang is not a structural biologist. He's not a chemist. He's sort of this, bench scientist, neuroscience researcher. And he's really specialist in biotech techniques. And this is why, you don't have a one-man drug discovery crew. It just doesn't work that way. I happen to know a little bit about each area because I've been a manager. But I don't know a ton about structural biology. That's what we'd have somebody like that for. And I don't know a ton about enzymology, but I've had an enzymologist. I don't know a ton about medicinal chemistry, but we'd have 3 or 4 medicinal chemists. So, they didn't have any of that. They had Dr. Wang. And it's just a very weird thing to design a drug without a chemist. It's hard. You need chemists. So anyway, he decides this drug binds to this sort of 5-peptide stretch of filament. Now the problem is that the theory they have is that this 5-peptide stretch of filament, why is this important in a 3,000 amino acid molecule or protein, megaprotein? That 5 amino acid section is really important. Why? Well, they're conjecturing that it is where alpha 7, which is the nicotinic acetylcholine receptor, that's where alpha 7 binds to filament. Okay. Now, nobody's proven that alpha 7 binds to filament at all. 2, nobody's proven that it's relevant at all. And in fact, we know that alpha 7 drugs don't work in Alzheimer's. So even if the hypothesis was true, of what consequence is it? Abbott tried to make alpha 7 blockers and alpha 7 agonists. And there have been clinical trials done for both in Alzheimer's. And both have failed. Both tries. Amp it up or shut it down. Neither worked in Alzheimer's. Absolutely no effect. So even if this wild idea that simifilam binds to the site where alpha 7 is supposed to bind to filament, so it stops that interaction from happening, which I'm going to talk to you in a second about why that's not a good idea. Even if it were true, there's no sort of consequence that is useful or interesting, right? So now let's talk about the actual binding event. The binding event that theoretically happens here, well, it probably doesn't happen because simifilam is not an electronically interesting drug. It has one place to make a really good hydrogen bond, and then the rest of the molecule just is not going to connect enough to the protein. The protein area is very, very flat. And that doesn't stop it necessarily from becoming a drug, but PPIs are notoriously hard to make. So PPI is protein-protein inhibitor, or interaction inhibitor. So PPI is when 2 proteins come together and you want to stick something around there like a little piece of glue to stop those proteins from coming together. It is one of the hardest things to do in chemistry. And when you do it, you have to make a really big molecule because you're trying to cover the surface area. And the more contacts you make, the stronger the bond because you're actually summing all of the free energy changes of the molecule. So if you only make one contact, no matter how good that contact is, it could literally be the highest affinity contact there is, but you're only going to get 3,000 kilocal per mole. So you're not going to get that much affinity out of one binding contact. You need multiple atoms binding to multiple atoms on the target site. Otherwise, you don't have anything. And that drug, by the way, is going to bind to everything. So it's very hard to design a good protein-protein interaction inhibitor. In fact, I'd say it's really hard without a team of 20 or 30 real good chemists and biologists. And so they did this all themselves with none of that. And this is the kind of work these guys have done since the start. This isn't a surprise. Cytokinetics, they made interesting drugs. And those drugs, they published in JMedChem, 30, 40 people, brilliant people, publishing really remarkable work about how they got their drug to interact with this protein that's not exactly an enzyme. And it was revolutionary work. That's what real research looks like. Cassava's never really had a publication of consequence, which is really kind of interesting. We'll talk about that later when we get to the clinical section. I'm still in the before human section. And so in the before human section, the preclinical section, we have these guys kind of bumbling around this protein, trying to figure out why it's important. So how'd they pick filament 1? Well, apparently, according to our friend Dr. Wang, who unfortunately is sitting and waiting for federal criminal trial. I know what that feeling is like. It's not fun. It's very hard to get out of that. So And I don't think, for the record, I don't think they should have gone after him. Scientific fraud is exquisitely common. It's unfortunate. And maybe this will send a message to all researchers to not fake your data and not, mess around with it. But there are many researchers, they're all competing for grants, and if it's just easier and faster to just copy and paste your Western blot to make it look good, people do that, they're going to do that. It's endemic in the industry. People fake their results. Oh, you want the mouse to have this kind of response? Well, just draw it in. Why actually get the result? Just make it up. And so that kind of attitude is obviously horrible. But there's a reason. There's a so-called replication crisis in science, and that's the reason. Give me just 2 seconds here. So anyway, how'd they pick filament A of all weird proteins? Well, they seem to say that Dr. Wang discovered that the real binding site for naltrexone is filament A. Naltrexone is a very important molecule in the opioid space. And it binds to opioid receptors. That's how it works. It doesn't bind to some mysterious different protein. It works by binding to the opioid receptors. It interferes with the ability of most opioids to activate one of the 3 opioid receptors, mu, kappa, delta. And the idea that the guy discovered that, actually, naltrexone and all the opioids, technically they work through binding this stretch of protein of filament A is sort of insane. Because, we know how opioids work. And one of the early patents that Dr. Wang filled out, and I think it was awarded, was that you can make a drug that looks like semifilam, bind it to that part of filament A, and it's the most potent analgesic ever. And, why that wasn't sort of taken advantage of by, say, Vertex, whose, new pain drug, maybe one of the biggest drugs of all time. Everyone's looking for a non-opioid, non-addicting pain drug. I mean, it's like one of the crown jewels of pharma. So he decided that that's what filament A does. Then he pivoted to cancer. Then he pivoted to diabetes. And now he settled on Alzheimer's. So he sort of tried to claim that filament A is involved in all these things, which is a little bit remarkable. But that's his story. So he keeps trying to sell filament A. And of course, the one company that's working on naltrexone and other types of drugs around opioids is Pain Therapeutics. So they get to know him, and he sort of keeps selling him on this other stuff. And Pain Therapeutics, after they failed all their pain drugs, they needed a second act. They needed a reason to pay Remy. They needed a reason to keep the company going. And they found one. He basically said, try this. Try an Alzheimer's drug. And they said, okay, we'll change our name because we're not Pain Therapeutics anymore. We're going to be Cassava. And so they went forward. And the next part of the story is a lot more interesting and a lot crazier. But it's important to know that, like, in medicine, the science has to kind of connect to the human clinical experience. If the science isn't there, it's very, very hard to connect the human clinical experience. And why is that? There are very, very, very few drugs in modern medicine that just work by accident. We used to be able to say 60, 70, 80 years ago that we didn't know how a drug worked because we didn't have the scientific tools we have today. Today, again, I want you to look at the last 40 drugs that are approved, roughly 40, 50 drugs approved every year for the last 5, 10 years, and tell me if you can find one of them where we don't know how the drug works. And I would say that it's extremely unlikely. It's a very rare thing where we don't know how a drug works. So if you can't explain how a drug works with precision, the simplest answer is probably doesn't. And here, the explanation of how the drug works is, well, it binds to filament A, even though we can't show you a crystal structure where it's actually binding to filament A. But it binds to filament A, and that stops alpha 7 from doing something. We don't even know what. Is it stop alpha 7 from docking extracellularly? Does it stop alpha 7 from recycling? Like, what exactly does that do? We don't know. Again, it would behoove you to sort of try to get a solid experiment that looks good. And so instead, we sort of have this vague idea that, it's just something to filament A. And to me, that's not good enough. You need an experiment that makes sense. Otherwise, everything downstream of that is like going to be 10x more skeptical. So it better be really good. This kind of happened with a drug. The last meaningful drug where we had no clue how it worked was called thalidomide. And thalidomide and its analogs, lenalidomide and all of its other progeny, we did end up finding out how they worked, and it sprouted a whole new area of chemistry. It was so mysterious and so difficult to understand what was happening with thalidomide, and specifically lenalidomide, which is very similar to thalidomide, that it just ushered in a brand new era of chemistry called protax, this weird molecular glue that tags, ubiquitin to remove an entire protein. It just doesn't stand to reason that something would naturally we just don't know how it's created. We didn't know how he designed it. It just happens to work. And what I encourage you to think about is the Elon Musk, rocket landing. So designing a drug that works for Alzheimer's by accident is like designing a rocket that lands itself kind of by accident. You need real precision. It's actually harder to make the Alzheimer's drug, in my opinion. You need the exact exquisite precision of that rocket landing, but even more on an atomic scale that you can't see. It's very hard. The last 100 clinical trials for Alzheimer's, 98 failed. So you're up against tough odds here, because this is not a disease we even understand that well. So you need to hypothesize why is Alzheimer's happening, which is not fully understood. And you need to make a drug that does something, and that something needs to be relevant to this disease that we don't understand. Pretty tough. So they kind of rush through this and just decide, okay, this protein, which apparently to Dr. Wang, who's hungry for research dollars, because he's kind of this fledgling, struggling lab guy, and you need funding if you're going to run a lab. So he's making stuff up. He got this company to sort of do this work. So he's got a corporate sponsor. He's got some NIH grants. It's starting to work a little bit. He's over here at CUNY. I went to a CUNY school for college myself. And the drug gets into human beings. Not a small feat. So what happens in human beings? Well, the drug's got this really low half-life, which again, chemistry has solved for these kinds of things. I can literally right now tell them how they could extend their half-life meaningfully. But any chemist could. And they didn't do that. They decided to go into the clinic with a 4-hour half-life drug. Nobody would do that, right? No Merck or Pfizer would sit there and say, oh yeah, 4-hour half-life, that sounds great. Let's give the guy 10 pills a day. Just add some fluorines, make an ester. It's not hard to elongate half-life. There have been hundreds of publications on how to do this. So, but they go ahead anyway into phase 2. And so in phase 2, phase 1, all you learn really is just your half-life and other stuff like that. So in phase 2, they start to dose Alzheimer's patients. And this is where it gets kind of crazy. They give the drug to 3 groups. One is placebo, one is 50 milligrams, and one's 100 milligrams. And in a small phase 2 trial, it's kind of hard to tell whether your drug is really changing Alzheimer's. Alzheimer's is a disease that we don't know for sure, but the disease could be taking place over 10 or 20 years. We don't really know when it starts. We only know when the cognition starts to fail and memories start to fail and stuff like that. But we don't know if that process had been going on for 10 or 20 years. That's why it's so hard to treat. Should you intervene 10 or 20 years ago? Is it too late to intervene once the memories start failing? It's really hard to know. I almost think of it like a neural network in software. If you start taking cells out of a neural network in software, think of them as weights and biases. If anybody here programs AI, if you start zeroing those out, it's called pruning. The neural network is fine, but after enough weights and losses get zeroed out, the neural network starts to fail. And there's not an easy way to restore that because of it's sort of entropic principles, right? Once the data gets cleaned out, there's no way to reverse it. The data's gone, so your memories are gone. So how do you reverse it? And there's some reason to think maybe we can't reverse Alzheimer's. Maybe once you're too far gone, you're too far gone. Nobody knows for sure, although the amyloid beta drugs seem to help a tiny bit. So anyway, they do this phase 2 trial. 50 mgs, 100 mgs, placebo. Let's run them wild. It's a poker game. And they give the drug to all 3. And it's a tough place to be in biotech because if the results are great, fantastic. But what does great mean? How likely is it that in 28 days you're actually going to see some physiological response? What are you really looking for here? Well, they got the results back, and they did these little memory tests on these patients. And it turns out that the best group of all 3, placebo, drug, and higher dose drug, 50 milligrams and 100 milligrams, I feel like it's a poker game and you're about to get your hand. The placebo had the best result, which, is not great when you're trying to make a breakthrough drug. You should be able to beat placebo for crying out loud, right? And placebo had this really nice result. The 50 milligrams, which is the low dose, had a slightly worse result And the 100 milligrams, the high dose, which you would think would work the most, had the worst result of all. So it's like the exact opposite of what you want. So if you saw this, you would say, okay, I don't want anything to do with this drug. If you were a responsible company, you'd say, you know what? We wasted a couple million, maybe 5-10 million. There's greener pastures out there. Why chase a ghost here, right? Like, let's go, instead of putting 100 more million into this dog, apologies to all canines out there, let's put, 100 or another, let's keep fishing. Let's find another 10 million in some other dog. When I start dating a girl and she tells, after 3 weeks, I realize that she has a cocaine problem and she's missing a leg and all this bad stuff. She's physically abusive to me. I don't say, well, you know what? She's a good girl. I'm going to keep going. No, I'd say, you know what? I'm going to go find another girl to date and maybe then I'll take it and advance it to marriage. But that's kind of how this is. And so they decide to look at this drug and say, I'm going to commit fraud. I'm going to take half the data and throw it away. I'm going to keep throwing data away until the drug looks good. And that's what they did. And this is like a bright red line of ethics that is just so disgusting. There's no word for it. So they decide that instead of showing that the drug performed worse than placebo, they were going to cut and splice and mess up the data until they showed that the drug did work. And that's what they did. After throwing out half the patients for various quote-unquote reasons, they were able to show that, in fact, the 50 milligram group did the best. Because the 50 milligram, as I mentioned earlier, was kind of already not too far from placebo. The placebo, they tortured until the placebo looked like a real placebo. No result. And the 100 milligrams, they beefed up a little bit to look okay, but not as good as 50, which is still puzzling. Most of the time, you don't get an inverse dose response. Almost always in medicine, the 100 is going to give you a better response than the 50. Higher dose almost never is worse than lower dose. Think about it. If you take 2 aspirin, you may not get that much more pain relief than 1, but you shouldn't get less pain relief. And so, that was a red flag to begin with. But here's the thing. When they released this data, they didn't tell anybody that they cut out half the patients. They kept it a secret. Only recently did we learn this when the SEC sued the CEO and his wife, forced them to resign. They were now out of the company. This is the guy I started the story off meeting 20 years ago. Very passionate dude. The company's his baby, literally. And he would, just months away from the phase 3 results, why would you resign? And the answer is, we don't want a guy who's sitting as a CEO of a company about to get arrested, possibly. He's definitely getting sued by the SEC, which is not a criminal arrest, but it is certainly serious. And, they basically decided to part ways. And they didn't even thank him for his 20 years of service or starting the company or anything in the press release. They just swept him under the rug and said, he's gone. We have a new CEO now. And maybe rightfully so. Messing up half the data until the drug looked good instead of the actual results. Wouldn't you be furious? I mean, if you were an investor and they showed you this data and they said, hey, look, our drug beats placebo. And you said, wow, that's great. That's a good sign. It's only 28-day data and it's on this quirky little memory test. But hey, it's a good sign. And then they didn't tell you that actually the original data showed the opposite. We just manufactured this data, tortured it until it looked good. You would be furious. And anyone would be. And to me, that's actually Lindsey Burns, Remy's wife, hasn't been indicted yet. And I actually think that's 10x the crime of Dr. Wang, who has been indicted for faking Western blot graphs. Western blot, look, it's not the right thing to do. There's no doubt it's extremely unethical. There's no doubt it's fraudulent. There's no doubt the DOJ is well within its rights to do what it's doing. But when you take human data and you say, these people didn't get better on this trial, but I'm going to change the data until they did. That, to me, is 10 times the fraud, and I think most people here would agree, than a scientist nervous for his funding, fudging data. He's fudging animal data. He's fudging protein data. It's not the scale of human clinical results. And so they get those results, and they're fake. And then there's another study. The second study is just as bad as the first. But for some reason, some of the people who like Cassava don't understand this. And virtually everyone I've talked to who likes Cassava, none of them have looked at another biotech stock in their life. I've looked at like 2,000 biotech stocks in my life over 20 years, painstakingly. I know a lot about medicine. I hope that is somewhat clear here. When you go like ham into a stock and you don't know the industry, this is the kind of thing that might happen, where you look at something and interpret it incorrectly because you maybe don't know how to interpret it at all. And so one of the things that we're seeing a lot of, and I just had this conversation with one of the largest stockholders of Cassava, who's this, I'm sure, kind of well-meaning guy. I mean, I don't know for sure, but like well, let me explain the new trial results. So Cassava does this interesting trial. Normally, if you're Pfizer or Merck or some normal drug company, you would say, all right, I got a promising Alzheimer's drug. I'm just going to give 200 people the drug. I'm going to give 200 people the placebo. I'm going to wait 6 months, see what happens. And instead of doing a phase 3, where it's going to be like, okay, I'm going to give 1,000 people the drug and 1,000 people the placebo, I'm going to wait 2 years. That may be what a normal phase 3 might look like. That's $200 million trial. I'm just going to do a $10 million trial. 200 patients, maybe 150 each, drug versus placebo, and I'll get a glimmer of do I want to make the big investment for phase 3. They didn't quite do that. They did something a little different. They gave everyone the drug for a year up front, which doesn't make too much sense. And then, this part makes a little more sense. For 6 months, half the people got switched to placebo, and half stayed on drug. So that's useful. The first year where everybody just gets drug, you can basically throw that data away. It doesn't mean anything. Why? The people who are rookies to this, the amateur armchair drug analyzers, would say, well, the results of that first year matter a lot because we want to see how well the patients did or didn't do. These people have Alzheimer's. They're not getting a placebo. They have no control group. You could easily make a control group. It's not hard. That's what a clinical trial is. But instead, they're giving all the people drug and no placebo. And you can't really measure, the result of that trial and interpret it in any reasonable way because there's no yardstick. It's like watching somebody hit a baseball and somebody says, well, how far did you think they hit that ball? Well, I don't know, 200 yards? And they say, well, it's actually 316. I was like, I can't blame the guy for not knowing. He's just eyeballing it. And if you had an actual measurement stick, you could make a rigorous kind of assessment. The reason we can't do this is no two trials are alike. Alzheimer's patients can do really well if they don't have, say, ApoE4, for example. They could do really well if they're young. They could do really well if all types of things. Depending on the original recruitment, the result of the trial will be better or worse. This happens a lot in biotech, say for cancer. You have a promising cancer drug. The last thing you want to do is enroll a bunch of people who are at death's door. You want people who are a little bit younger, a little bit healthier, their tumors are a little bit smaller. Those are the kinds of people, you're going to support them at a really good cancer center. You're not going to go to Dr. Joe's in Long Island. You're going to go to Memorial Sloan Kettering. That's the kind of thing that drug companies do, because when they report, okay, our first 20 patients, they lived 18 months. Normal person lives 12 months with this disease. They want it to look good. They don't want to say, well, we still like this drug, but these people live less long than normal. You want to put the best face forward. And with an open label trial, meaning there's no placebo or control, you can even just go to the study sites and say, hey, look, I want this study to look really good. When you evaluate these Alzheimer's patients, try to look at the bright side of it. And it's not hard to do that. When you evaluate somebody and you say, I think they're 5 out of 10 instead of a 4 out of 10. Or you might be, when you get drunk, you might think every woman is a 10 out of 10, or every man is a 10 out of 10. I certainly know people who do that. So it's without an actual control group, it's almost impossible to come up with a rigorous way to evaluate a medicine. It's like irresponsible to think that you can look at an open label period and decide, all right, if they're getting better or they're not getting better, because, certainly it would be weird if their Alzheimer's completely reversed or something like that. And in tumors, if they had a complete disappearance of their tumor, you could say, look, I don't need a control group. You don't need to be a scientist or doctor to know tumors just don't disappear, right? But that's not what happened here. The argument is that they declined more slowly than expected. And I'll get to that exact data in a second. So they do this trial. And in that first year, the patients are happy-go-lucky. They're getting their drug. This period, as I said, doesn't really make any sense. Then they do the 6-month period. And this looks like a controlled trial. Half the patients will switch to placebo. They won't know who is who. The other half will stay on drug. And again, they don't know who is who. This trial failed. And it failed conclusively. So this trial, at the end of 6 months, they unblinded. They did a proper kind of like assessment of did the drug work or not. And they clearly stated that the primary endpoint was not met, that the big scale for Alzheimer's is called ADAS-Cog. It stands for like activities of daily assessment score, or Alzheimer's daily assessment score, or something like that. I don't remember exactly, but it's the cognitive subpart of the test, which measures your cognitive ability, which is very important in Alzheimer's. It's considered one of the gold standard ways to measure Alzheimer's. And so they do this ADAS-Cog test. And what they find is that the drug group loses 1 point, and the placebo groups loses one group. The placebo group loses 1.5 points. And this is like really a minor change. The standard deviation is probably like 3 or 4 or 7. So 1 point difference, there's not even a 1 point difference. It's a half a point difference. And on a standard deviation of 6 or 7, it's really not a useful drug, right? And that's why the p-value is not statistically significant. And that's usually the end of the story. Your drug's over. It's done. It doesn't work. And that's fine. Move on to another drug. It's not the end of the world. You can find another medicine. But again, these guys lied the first time, so they're going to lie the second time. And what they tried to do here is they couldn't sugarcoat it this time. And possibly they couldn't do that because there's more people involved. There's, the FDA is not quite involved yet, but there's the clinical trial sort of consortium that's involved. And each doctor who's doing the trial is keeping notes of their own results. So if their own results say X, and then they see the press release from Cassava that says, oh, the study was fantastic, they'll say, hold on a second. Something's weird here. And you have this whole DSMB, and there's a lot of people involved that have to get the data, so you really can't lie too much about it. But the company did anyway. They manipulated the data. I still don't know if we can trust the data they gave out that I just repeated, the whole half a point better. I would probably expect that it's actually a lot worse, but I'm taking them for their face value. And so what ended up happening next is very interesting. They got a failed trial. So what they do is they decide to split the trial into 2 parts. They said, if you look at the mild patients versus the moderate patients, the people who are less sick, the drug looks a lot better in that group. Well, you can't really do this because it's kind of like saying, well, the primary endpoint of a basketball game is points scored at the end, right? It's not how many points did I score in the first half. It's not how many rebounds did I get. And so it's like if I bet you $20 on the Knicks game, Knicks lose, and you say, hey man, where's the $20? You say, actually, I won the bet. John says, what are you talking about? My friend John is in here. I say, John, well, I know we lost the game, but we scored more points in the first half. And he said, Martin, look, I thought I was under the assumption that when we talked about betting on the game, we were talking about points at the end of the game. I said, well, that didn't look so good for me, so I changed it to points in the first half. And I did that after I saw the results, not beforehand. It'd be one thing if beforehand I called John and say, hey, can we change the game, the bet to just first half? I think we'll smoke you guys in the first half. Okay, we'll bet on that. But no, I looked at it after the fact and I saw that we scored more points in the first half, but they blew us out in the second half, so we lost the game. And I said, don't worry about that second half. Let's just look at the first half. It's insane. But if you try to tie it to a theory, for example, in Alzheimer's, the young people, or the people that haven't experienced a lot of Alzheimer's yet, their disease has not progressed, maybe those guys are too far gone. But you could actually make the reverse claim too, that you want to treat the people who have presented with actual disease, and the people who are mild are not far gone enough to benefit. So there's no real rhyme or reason to say, oh, I need the mild or the moderate. And by the way, the drug didn't exactly look great on mild either. There wasn't a huge separation, but there was virtually no separation on the moderate patients. So it's this real, insane data set and this random, interpretation. So the big part of the interpretation is they put the patients, after this, mini trial, they put the patients back on another 6 months of all open label Simiflam. So they get 2 years of total data on all these patients. And it turns out that the mild patients did not decline very much over 2 years. In fact, they basically didn't decline at all, whether or not they got that 6-month interregnum of placebo or drug.
typically, if a drug is working, when you take it away, your effect drops dramatically, right? So like if I take my asthma inhaler for 6 months, I can breathe okay, et cetera. You take my asthma inhaler away, or you change it to placebo instead of albuterol, I'm going to start huffing and puffing. I'm going to start coughing. I'm going to start being short of breath. I'm not going to sort of be able to breathe. So it's hard to reconcile that in that 6-month period when they took the drug away, nothing bad happened to them. But when they put the drug back, they didn't get better either. They just kind of stayed flat. At least this is in the mild patients. And the only way to save this, basically, from all the fraud I described earlier, the hacking of the data to reverse that the drug was worse than placebo to better than placebo, required not removing like a couple of outliers. It required a whole redefinition of the study without telling anybody, which resulted in SEC fraud. The preclinical results, which were very mysteriously stupid and like fraudulent as well, that resulted in the indictment of a guy. Literally, he's going to jail. So the only way to hold this together is this theory. This is all the longs have, which is, I feel bad for them, is that these patients did not decline over 2 years. But there's a problem here. They're only looking at the mild patients. And in any group of patients, in any distribution, right, I encourage you to go back to college in your head and think about a probability distribution. There's always a right tail, right? The best portion of the patients will look good, and the worst portion will look bad. Just like if you ran a race, there's going to be the top 10% who finished fast and the bottom 10% who finished slow. I'm going to be in that group. But you can't just sort of take those and say, wow, look how fast these guys are. You got to look at the whole population. And if you look at the mild patients, they actually did a lot worse than you would have thought. So if you average them, which I did, and I'll be releasing some of this data, I've looked at almost every meaningful Alzheimer's trial ever. And it shows that this is exactly what you would expect in Alzheimer's patients. And the claim that, well, there's never been a drug that kept you stable on Alzheimer's is completely not true. There's actually a ginseng study that showed that. And there was also a study from a drug called Dimebon that showed improvement. They didn't just stop declining or stay the same. They actually got better. They gained cognition. I was going to take that drug just for studying for tests or something, or doing my work. That drug ended up not working out, despite the phase 2 trial looking like it was really good. That drug ended up failing and costing a lot of people money. So you can't trust these phase 2 trials very well, especially if they're uncontrolled. That trial was controlled, well done. It was published in The Lancet. You don't get published in Lancet by accident, and it still failed. So these guys are hanging their hat on this half of the phase 2, which failed, the period where it was controlled. Half of that phase 2 looks like the patients are doing better than they would normally expect, even though this is not a controlled trial, even though we have no idea if they even enrolled the right people in this trial. There's no control group, so they just look like they're doing better. So again, against the backdrop of 98% failure in Alzheimer's, because we don't really even know what the disease means or how it works, the preclinical fraud, which I haven't even gone to great detail, but just looking at the Filament idea should raise eyebrows, and then the fact that the guy who invented the whole idea is waiting federal trial. The phase 2 where Remy's wife manipulates the data so that it looks good secretly behind everyone's back. And then finally the failure, the just abject failure in the phase 2 in the controlled withdrawal period. All 4 of those things show you that it's over. I mean, there's no way this drug could work. And again, when you think about the odds, I actually was challenging another short hedge fund manager who said there was a 5% chance because of p-values that it would work. That's actually not true. So I made a program and I put it on my GitHub that's a p-value simulator for how do you calculate these things. It's true that the 0.05 is your ability to reject the null hypothesis, but it's also given a data set. So if you have a data set with no effect size, there's too much volatility in the distribution if the standard deviation is anywhere near the standard deviation we normally see in Alzheimer's, that the chances of this drug working randomly is close to 0. And again, I think that you have to think about drugs working as difficult as landing the Elon rockets or catching them in midair. It's more difficult than that. The feat of having a random molecule stop, a disease. In the search space of molecules, I want you to think about it as sort of 20 to the 8th power. There's about 8 organic sort of chemistry atoms that make sense to use in a drug. We know what they all are: carbon, nitrogen, hydrogen, oxygen, sometimes, and that's mostly it, but sometimes a fluorine, sometimes a sulfur, sometimes a phosphorus, but it's really CnHO. So you have about 20 to 40 atoms that you got to place in a molecule, and you have around 4 to 8 as your exponent. There's a lot of possible drugs. You have to find the one that's going to fix somebody, that's going to save their life. It's very hard to do. And doing that by accident, drugs just don't work by accident. I think the odds of this drug working are virtually zero. And you can short the stock, you can sell calls, you can buy puts, basically with impunity. It's a $1.3 billion company. I have literally like notebooks that are probably worth more than this company. Like a single page from one of my notebooks is worth more than one of these companies, than this exact company today. So that's my hypothesis. Happy to open it up for questions, comments, debates. Happy to debate any Sava bull who's brave enough to chat with me. Maybe it's this guy.
Hey, what up, Martin?
Hello. Do you have a Sava position?
No, I would agree with what you're saying. It's really unlikely that anything would really go through with this company. I think the stock's just going to be destroyed as soon as this comes to light.
Yeah, it's mostly come to light. I think that ever since the Wall Street Bets era of shorting, hedge funds have been a little bit scared of shorting. I remember talking to a friend who's a top hedge fund manager in this exact space 10 years ago or so. And I said, I like this short, I like this short. And I was, we used to trade together years before. And he said, Martin, I don't short anymore. I said, what? And he said, I don't short anymore. I can't make money shorting. All the stocks are going up all the time. I said, man, you can't quit the short club because like eventually the market will go down. Eventually we'll have a bear market. And pretty much right after we have this big bear market. And so basically, it's one of these things where a lot of hedge funds aren't shorting because for a long period, it just didn't make sense. Being long only is kind of the product they wanted to sell. The biggest biotech fund is called Baker Brothers. They're long only. But what's interesting about that is then after this sort of period of like terrible performance, hedge funds started to think about shorting again. And guess what happened? GameStop went from, like $3 or whatever to 400. And it bankrupted a hedge fund. So people basically said, why the fuck would I short? I don't want to short anymore. This is a tough game. I hate shorting stocks. Let me just take beta, or let me short an index or something. There's got to be a better way than to get alpha on the short side. I am a very dogged, stubborn guy, probably too stubborn, and I don't care. I think you can still short biotech stocks. A lot of them go down, and this is one where I think I've articulated this is maybe one of the best shorts in many years. And, it's just, I think, speaks for itself. So I think that when you say that, like, this comes to light, it's all to light. I'm not some, like, super smart guy that's, like, figured it all out and, I got them. I'm just reading the news. I'm just reading what's out there. The SEC complaint. I am not a fan of the SEC, but the SEC, and many others are not either, but the SEC complaint, basically puts it very clearly that the CEO's wife, the head of kind of, I don't know what exactly at the company, basically seems like she was the number 2 at the company. She basically got the data. She looked at it and said, this sucks. Let me figure out a way to present this in the best light possible. Now that's not like the end of the world. Like maybe that's okay to do, but you have to show the original data and say, this is how we went from this to that. And then it's up to guys like us to say, this makes sense to me. Or say, it doesn't make sense to me. So for example, let's say you had 60 patients and 2 patients horribly, tragically got into car accidents. And the company said, we got to exclude those 2 patients. So we're going to go from the sample size of 60 to the sample size of 58. You say, how unlucky it would be that would happen. And the study would have worked if not for that. I could kind of buy that. I might take a chance on that. But you got to disclose it. You can't just hide it. And then if it's going to materially, dramatically affect the result, like going from a success or a failure and switching it completely to a success, I think you should disclose that, you manipulated data very heavily to do that. And they didn't do that. Well, the last thing I didn't mention in my big monologue before I opened it up a little bit for questions, and this is maybe the most important thing, which I neglected to remind, and this company kind of knows no bounds. They've never published a clinical trial of their work. So the controlled withdrawal trial, which failed, or this 28-day trial, which they manipulated to work, neither have been published. And let me tell you something. These journals would love to publish a big Alzheimer's success. New England Journal would probably publish it. And if not, maybe Lancet or JAMA Neurology or any of the big neurology journals would love to say, wow, you got the most exciting new neurology drug. You should let the world know. You should get people excited for your phase 3. You should get people excited to prescribe it. But there's one problem. When you submit your manuscript for publishing, it has to go through some rigorous peer review. And some of these questions that I've asked are going to be the exact same questions that they've asked. And when I mentioned earlier that in that controlled withdrawal trial, they got a 1 point of ADAS-Cog for drug in decline and 1.5 for placebo. It was a little bit better, but really meaninglessly better. I'm not sure they were telling the truth then. And I think that maybe if this actually went through publication, that we might learn the actual truth. You cannot simply trust a press release from a company. I hate to say that because, look, I ran a drug company, and I hope people trust my press releases. But, the publication by a third party, the same way you trust an audit from an auditor, Pricewaterhouse says, hey, you can believe me. The peer review process for clinical trials is a little bit of an audit. And I think the FDA briefing book, if there's an advisory committee, is a really good audit. When those briefing books come out, a lot of people read them and say, whoa, this is way, way different from what I expected. This isn't what you told me. And that happens a lot in biotech. And again, I feel for Matt, who I think has bounced from being disingenuous to sincere and back and forth. And I played a little bit of a troll needling him a little bit. But at the end of the day, nobody should be jumping into biotech stocks with all their money firsthand. I play a little bit of poker every now and then, and when you see somebody, and I was this guy at first, when you see somebody come with a bunch of chips and they're like, oh yeah, I love playing poker, let me just go in on any hand, you raise your eyebrows, and you can see the other pro poker players at the table, and they kind of have a little smile, they raise their eyebrows and say, wait a second, this guy doesn't know what the fuck he's doing, does he? And this is exactly what that is. And every time this has happened, for 20 years, shorting these stocks, every single time, the long buyer is so convinced that they're right. And I'm pretty convinced I'm right here, but regardless, to be brand new to a space and have no humility and just say, I'm right, there's no way you guys are right, I'm the one who's right. It's just sort of man, you made your money in software, keep doing that. You know how many opportunities there are in software right now? Just keep doing software, dude. Why do you want to, put a third of your money in some biotech stock that you clearly don't know anything about? And so I had a lot of fun earlier talking about the inability for this drug to actually bind to its purported binding site, the lack of structural biology, the lack of a drug that was supposed to be a PPI, protein-protein inhibitor. This is not a drug that can be a protein-protein inhibitor. In a PPI, you have to form molecular bonds, hydrogen bonds usually, with the target, and you add the bonds up. I learned this after making drug discovery software. If you to determine the affinity of a drug, obviously physiologically, you can see how much drug it takes to affect a reaction. In silico, you actually add up all the bonds. You estimate the bond strength of each bond. So a really good hydrogen bond can be 2,000 kilocal per mole, and you need 10 of those to get a really good drug, or at least 5 or 6. There's really only one good hydrogen bond donor on this drug. It's the carbonyl oxygen. After that, it's really slim pickings. And even in the most ideal binding construction, you really don't have a very potent drug. And we know the PK of the drug is rather bad. So this isn't a good drug, even if the filament target was perfect, which we know it's the opposite of that. It's not a target at all. It doesn't do anything. You still would not really have a drug here because you would not be stopping a PPI. A massive protein, imagine a massive protein, like a ship from Star Wars. I never was a Star Wars fan, but one of these big galactic ships and this other big galactic ship, and they're going to dock in the middle. If you tried to make a drug that was a tiny little garbage pail or something that was going to stop that reaction, it's not going to work because the hydrogen bonds from the massive protein interacting with the other massive protein are going to be extremely well complemented. And the shape complementarity of this drug, it doesn't exist. It's a very flat binding region that they claim. Very few people have ever, even the short sellers who wrote the citizen petition, nobody ever bothered to look at the crystal structure. And this is like a very flat surface on the protein, which is like, how do you bind that? How do you bind that without binding every other protein in the human body? So it's really not a drug. This drug's a piece of garbage. And you can fake the phase 2 data all you want, and it all failed anyway. So the interpretation here is not there. Again, I'm also happy that hope springs eternal and people do get fooled. Poker wouldn't be very fun if every time you sat down at the poker table, every single guy was a poker pro. That would be less than ideal. When I go play chess, in chess tournaments, I get smoked by all these like little kids. It's so embarrassing. And it's like, sometimes I get a win, but most of the time I get smoked by these little kids who are training chess really hard. And it sort of sucks to go to chess tournaments because they get killed every time. Stock market's a little easier. And some of these other markets are even easier. So semi-cynic, I know you've been waiting. So what do you want to say?
Hey, yeah, I think that's a really good place for me to insert my thought, which is that you're bringing a lot of good fact-based findings to a thesis that a lot of people are centering around feelings. And that makes it especially hard to short because you are waiting for people to change their feelings based on facts that are out there in the open already. So from a shorting perspective, it's very difficult to have some concept of return on investment or timeline, to fit this into a constructed portfolio. I would love if you could just talk on that for a bit.
Yeah, strongly disagree. Your job as an investor is to sell garbage for very high prices and buy gems and diamonds for very low prices. And it's not easy. Sometimes you think something's a diamond and it turns out to be garbage and vice versa. But in general, systematically over time, if you do that, you should make money. Obviously, shorting is dangerous. There are ways to try to create alpha shorting without necessarily risking your whole firm. Nobody wants to do that, or your whole personal account. In the past, I've been willing to do that anyway, but, for most people, they shouldn't do that. They should, somehow cabin their risk to a limit where they say, the most I'm willing to risk of my portfolio is 1% or 5% or whatever. So if I'm extremely wrong, like, I'm not good at what I do if I kept doing this over the long term. Anybody could be wrong once, but over like hundreds of decisions, if I'm constantly wrong like this, I should just maybe stop trying to be good at this. So it's okay if you're wrong on Cassava. What wouldn't be okay is if you tried to put half your portfolio in it, or you somehow you literally put your neck into the guillotine and you said, I dare you to chop me. Eventually life will chop you. And I think that, that's why Buffett once said that, he would never play Russian roulette. Even if the gun had 1 million chambers and 1 bullet, he still wouldn't want to play if it somehow risked his whole firm. And I think that's fair. Nevertheless, things like this inspire greed in the reverse direction. There's a lot of greed about, well, if this works, the stock goes up 50x. Yeah, that's true. It probably may go up even more. But there's a problem with this, which is, you can be very greedy and excited, and you even get a little bit almost like, I don't know how to put this in a way that makes sense, but like, almost like high. You get like this tingle of like excitement. But it goes the other way too, where you say, oh, this is a fraud. There's no way this works. And you should temper both sides of it, where you're like, okay, yes, it's probably not going to work, but is it sane to put half of my well-earned money into this? No, it's not sane. Is it sane to do 10%? Okay, maybe you get a little more sane. And you just have to decide for you, what kind of volatility do you want in your portfolio? So for me, you're more worried about, okay, will this trade pay? Yeah, that's a big question. But I don't know, when I play poker or even when I invest, it's important that most of my trades pay, right? Otherwise, you're not going to keep doing that activity. But you know as much as you need to know here that with pattern recognition from the past, some people who are like really deep divers, they just go too crazy looking into these things, that, this is a fairly good risk reward short. Now, the past of like, okay, yeah, GameStop happened, AMC happened. Sure, there was a time and a place where shorting anything was dangerous. I think markets are more sober and normal now. We're out of the 2020 like mini bubble. Biotech stocks, plenty of them have gone down a huge amount. They're not like hanging in there despite fraud. So, like, to me, I think it's a safe period. And again, I'm just spitballing and guessing because I don't know any better than you do. But it seems to me, talking to some of the Cassava bulls, that, like, if the trial fails, they will not somehow bid up the stock. They will not stick around. Like, these people are a lot more rational than you think. I talked to one guy who's a software engineer at a major company. And he basically said, look, I came into this thinking there was no warts. Now I'm thinking about exiting because these people have gotten arrested. All this stuff has happened. I didn't know about any of this. And so these people are not as dumb as we think. There are some of the louder ones that are very dumb. But, and some of them are now making a point of pride. I can't sell. That means Martin's right. Or whoever's right. Adam Feuerstein or whoever. That means they're right. And they've won. No. You win when you take your money off the table in a really risky situation and safeguard your money. You win. But regardless, I think that, that kind of stuff that you just talked about, like, the short might not work, I'm trying to time it right. To me, like, that luck is distributed over enough events, right? So over 500 trades, you will got the right market sentiment right. You will get the wrong sentiment in an equal distribution amount. You will be extra rewarded sometimes. You'll be extra penalized sometimes. You'll be right sometimes. You'll be wrong sometimes. All that stuff distributes equally. The only thing we can really rely on is our skill. And our skill in analyzing these things fairly and just placing the bet. It might be the kind of thing where, well, let me take a step back. One thing I'll say that's very important here is that when these results come out, if the company tries to spin them, there is certainly federal law enforcement interest in this first. But the second thing is the spin has to sort of exist within the narrative that they've promulgated in the first place, which is that the mild patients seem to do better. And I've seen this many times, and many experienced biotech people will echo this, which is one of the biggest dangers of the subgroup analysis, other than it's like a faulty statistical idea, because you need to make adjustments for multiple comparisons and all this other reasons. One of the big faults of subgroup analysis is you have to stick to the narrative. So I was once, the whole mild moderate thing is a very common trope in biotech. And so one of the times I've seen this happen was when somebody said, well, first the mild patients did better. Then the moderate patients did better. Then they tried to go back to the mild. And it's like, which is which? So they can't really stick to this subgroup analysis. If the primary endpoint fails, which is almost certainly will, they have to find a way to explain it that doesn't involve, that has to stay consistent with the mild thesis. If they try to now say, well, ApoE4 genotype patients did really poorly because they're too far gone. But the ApoE2 and 3 genotype patients, no, they did just fantastic. Somebody's going to raise their hand and say, well, what happened to the mild thing? And eventually you get to this place where the company's saying, well, on Tuesday, women named Sally do really well with our drug. Everyone else, it doesn't work. And that's a really tough place to be. So that's why if this trial meets its primary endpoint, look, the shorts are cooked. It's going to go to 1,000. It's fine. But if the trial doesn't meet its primary endpoint, they can't really say very much that is going to be believable. And two, sometimes in these subgroup analyses, you really will not find a subgroup that works. If a drug really doesn't work, it's hard to spin by fishing for a subgroup, especially if the main subgroups are unavailable. So I would argue, when this trial does come out, the effect size will be 0 for mild and moderate. It'll be 0 for mild, 0 for moderate, 0 for severe. And yes, maybe they can fish for some obscure subgroup that might work, but I don't think they'll be able to do that. And more likely than not, we'll actually get a press release that says something like, Cassava discontinues simifilam, or Cassava, gets negative results and is hopeful for the second phase 3, but the drug just doesn't work. So for them to try to spin something is tough. Now they could delay the trial, in which case you have to sort of be careful that you're not making some weird duration bet instead of a directional bet. But if they delay the result and say, the result's not very good, or we're going to delay it, we just want to see both phase 3s at once, they can try to play that card. And that's I'd be happy if they play that card, because it would sound like they are not confident, and they, more likely than not, the trial's going to fail. And maybe it already did fail, because I think they actually do have the data right now. So one thing you could do if you were a scheming, devious person is you could combine both trials and say, okay, if you combine both trials, which they statistically, legally can't do, but if you wanted to do that, and we added up all the patients across 2 trials, maybe it's easier to find a subgroup. So I just don't see how they wriggle their way out of this. And look, a lot of people tried to short this a year or 2 ago and it didn't work. So ultimately, those people, some of the people have been burned. And I think this trade for me is really good timing. It's hey, I got into it a few months before the phase 3. Now we're like days away or weeks away from the phase 3. So for me, it's been perfectly fine. But, for the longest time is sort of ticking. The river card, so to speak, has to turn up. Sorry if that was a little long-winded. Sometimes I talk to myself too much. Does anyone out there long Cassava who has like some small amount of testosterone that they would maybe, be willing to come up here and argue with me a little bit? It's very unlikely, but just in case. It's not smart if like the tornado's coming and you're just like, you know what? I'm just going to close my eyes. The tornado's not going to be that bad. Let me just turn around. If I turn around and don't look at the window, tornado will be fine. What do you think, B. Bolin?
Hey, Martin. Brian Bolin. I worked at Zacks. Work currently at Zacks. I write a newsletter and picked Cassava a couple of years back when it was $9 and sold it when it was 90. And I'm sorry I missed probably part of this, or definitely late joining. There was a thing where there was another company, if I remember, that had another Alzheimer's drug that got FDA pricing that was nearly absurd, and that kind of lit the fire under the whole thing that is Cassava, right? Did you review that part of the story? And is that, that run from 9 to 90, is that what you believe is keeping so many people, bullish on this name as opposed to, looking at the data?
Yeah, that's a good point. I mean, I think that people will change their mind over time to fit whatever narrative is like the most comfortable. I'll give a stupid metaphor, but you can imagine people do this all the time in their normal lives. And so back then, the FDA approved Aduhelm or aducanumab without really great data. And people were really surprised. And it came out that Biogen like really targeted personally, a bunch of people at FDA to like squeeze all the relationships they had to get this approval, which was extremely controversial and maybe in my opinion, the one red flag from the FDA in like decades of good work. This like really kind of was like a black eye. At the same time, giving people more options to more drugs. It's not like this drug is dangerous. Just saying, okay, if you want to try it, you can try it. If a doctor thinks it's a good idea, it's a good idea. It's not like the worst thing in the world, but look, they should not be approving drugs that don't work. And lo and behold, Biogen has discontinued the drug regardless, and they've replaced it with a drug as well as Lilly, both of whom have met their phase 3 endpoints very convincingly. And those drugs are now FDA approved and they're working. But that moment, it certainly seemed like the FDA was going to approve anything that came their way in Alzheimer's. And that certainly would be bullish for Cassava or any other company developing an Alzheimer's drug. But you need something. You need some efficacy. You can't just sort of, do nothing. You have to show that the drug sort of works. So I think they're sort of up shit's creek because the Aduhelm thing was so toxic for the FDA that where we normally expect them to like behave rationally, they behaved a little irrationally here. I think the Aduhelm thing was such a bad experience that the FDA is not going to sort of repeat that. There are plenty of people who have Alzheimer's out there. It's not a rare disease where it's like you've got there's 6 people with the disease and you can't even find them, so you can't do a trial. There's millions of people with Alzheimer's. It's easy to find them. It's easy to do a controlled trial. The world's not suffering if we wait a year to see if it's real or not. It's really not that urgent. Of course, it's a terrible disease. It is urgent, but it's much better for us to find out for sure than to rush a drug wildly into the wild. So I think you're right that like that big run was caused by that, and that dropped all the way down. The guy got arrested. The CEO had to leave. All this stuff happened. The SEC
was that the stock where the FDA gave the pricing at something like it was some absurd level like $68,000 per dose or
yeah, the FDA doesn't
or I don't know who did I don't know who did the pricing, but allowed the pricing to be
the company's
insurance claim on it was
companies.
It was an egregious amount, whatever it was. I forget the exact numbers.
Certainly it could be seen as egregious. I would argue that they set the price at around 50, 60,000. The company set the price. Medicare agreed to pay.
Right.
I believe. But regardless, I do think an Alzheimer's drug is worth a lot. Saving somebody's cognition is, it's kind of all you have as a human. So it is very valuable. That specific drug didn't do a very good job of it. So the price was really not a good value. But many companies have agreed, like Alzheimer's drugs are going to be expensive, and they should be because they provide so much value. But they actually have to provide that value. So it's a little weird when you charge a premium price without having an actual premium product. But I would agree that, like, everyone in general was kind of taken aback and annoyed by that whole experience. FDA, investors, other Alzheimer's drug companies who are like, wait, now is my crappy drug also approvable? Like, what the heck? And then what the funniest part of all was that nobody used the drug. I think we all kind of tend to think in the drug industry, and even investors, we kind of think that doctors are kind of sheep that will just prescribe whatever. And the litmus test is saying, like, well, if my dad has Alzheimer's and a doctor has an FDA-approved drug, why would he not use it? And the reality is they're going to look at the data and say, wait a second, I don't like this drug. I don't want to use this. This is not that useful. Get it out of here. I'm not going to waste time and waste money on a drug that's not going to really help my patient anyway. So what was really ironic about it all is the drug got approved through all this strum and drang, like there's all this pain, and then nobody prescribed it. It was like the funniest, like, comeuppance for Biogen, where it was like, nah, you need to get people excited about a drug. It's got to actually work. And I'm glad that pharma has gone to that era of, like, doctors actually pay really close attention to this stuff. Whereas in the past, it's like, oh, we got a new drug from Pfizer for Alzheimer's. It's great. It's going to be great. And it does $1 billion in revenue, and it doesn't actually even work. So this drug couldn't even do a couple million in revenue. It was pretty funny. And people with Alzheimer's are very desperate. So it sort of shows you the intellect of physicians sort of looking at this and saying, it's got to be more convincing for me to prescribe it.
Do you expect any impact from on the stock price from your spaces here?
No, I am going to write, like, a long report about it and release that. I've done this a few times in the past where I just lay out all my thinking. I've sort of summarized it here, maybe even before you got here, but I'll
definitely listen to the replay.
Yeah, I mean, I try to be objective, but, like, because I don't have an axe to grind. I have no axe to grind here. If anything, like, I really like Remy. He was one of the first guys I met in the industry 20-something years ago. Was my boss's college roommate, and he's a nice enough guy. I hate that, like, all this stuff is happening to him, but in some ways he's also reaping what he sowed, and it's frustrating. I also care about people with Alzheimer's. A lot of us in the room are going to eventually get it. It'd be nice if there was a drug for it, but we can't will our way to that, right? Like, all the hopes and prayers that this drug work are not going to change whether the drug works. It's deterministic. It just either works or it doesn't. And it unfortunately probably doesn't work, and it actually wasted a lot of resources. That $100 million or $200 million that was spent on this clinical program could have been spent doing something else. And, it's kind of frustrating because kicking the can down the road where it's a fraud, to me, is like, it's kind of just so unethical because in pharma, you can't change things. In software or hedge funds, there's always a hope that your fraud might reverse itself. That, your actual positions might start making money, or your software sales might boom. But if you lie about drug data, the drug's not going to get better. Like, it's a static molecule. Like, it does not change. So it's really unfortunate that they sort of chose this route and put the whole world of biopharma on, like, this, like, weird goose chase for the final result. And I hope that the new management, who presumably doesn't want to suffer the same fate of the old management, which two had to resign and got SEC complaints against them, and one got indicted and also got an SEC complaint. And that's kind of all we're at for now. I hope the new management is just going to tell the truth when this new trial result comes out. And I think that short sellers can play a good role in the market, keeping things honest, because we can all lie to each other and say this is going to be the cure for Alzheimer's, but we'd be lying to each other. And the results so far show the opposite. So, like, no matter how much we want to believe, we have to look at reality. And I think the new management team is competent and sober enough that they're not going to be like, oh, our drug didn't work for all people, but, if you have ApoE4 Alzheimer's and you've been diagnosed within the last 2 years, then our drug really works well, because everyone's just going to kind of laugh at them, and the stock will go to zero, and the few true believers are going to sit there and cry that, oh, it's the shorts, or it's Mossad, or it's some, like, crazy manipulation. It's like, dude, the drug doesn't work. I've looked at hundreds of drug stocks on my stream, and I don't go into it with any, like, personal animus of like, oh, I have to prove this one is good or bad. I just jot down in a notebook like, oh, I like this one on this day. I didn't like this one on this day. I like that one on that day. And I'm not going to be wrong every time. But I also, I'm just telling it how I guess I look at it. I don't have any devious conspiracy in me.
All right, keep up the good work. Enjoy your streams all the time, buddy. Thanks.
Thank you. Okay. I don't think there are too many more questions. I see Bill. Love you, bro. And, yeah, I don't have a lot else to add. If there's a Cassava bull who wants to try to make a claim, as to why they're bullish, I'm happy to hear it out and I'm happy to debate. But, I promise I won't stoop to any ad hominems. I stick to the data. But I think that it's crickets and silence because, it's just very, very hard to defend this sort of situation. Maybe Anish is a bull.
Hey, Martin. Hey, how are you?
Good, how are you?
Hey, good. So I'm a software engineer. This is my first biotech investment. I'm going purely based on ChatGPT, and I'm not putting all of my life savings on it. It's a small but substantial amount. So I did spend a lot of time researching on it. I relied a lot on ChatGPT to fact check things, right? So what I found is there are like arguments that you're making, like the mechanism of action and the issues with the foundational research. What I found is like there is a lot of other things that substantiate it works, like the TR Fred assay and the biomarkers were verified by Contrix. And then the Pender, Susan Hendricks was saying like it's like unheard in like in Alzheimer's that like patients get stabilized. So that's on the mechanism of action. Now, I understand your point on phase 2B, it's cherry picked, but it's only a 28-day trial, right? So I don't know, even if it worked, if Cassava's argument was like, hey, it worked on 28 days, we are able to stabilize patients, I'm not going to put my money on that. It's a progressive long-term disease, right? You need to see like 6 months, 1 year, or 2 year studies to see the actual results. So, yeah, I mean, it's a safety study, and we have other open label, and like we have more confirmation that the drug is safe. Then, okay, I understand you don't give a lot of value on the open label studies. So my question is like, is it so easy for you to find like mild and medium Alzheimer's patients and create like they don't have Alzheimer's and like have them be stable for 2 years and kind of like we have FDA, SEC, everybody investigating them. So if I am the investigator, first thing I'll be checking is, hey, is these patients are actually mild or are they frauding the investors? Right. So they have the MMC score, they have the ADAS scores. That kind of confirms their where they are in the mild or medium Alzheimer's. So I was debating with all the short arguments and the bull arguments with ChatGPT, and I'm getting like more than 50% odd for success. And like you confirmed, like if it's successful, it's a 50x winning. So it's worth putting some money there and like roll the dice. Why now? My question is like, what are the biggest holes? Like, why you think it won't work, or like, why am I wrong here?
Yeah, so I mean, I have a lot of experience. I've bet a lot of money over the long run on binary events, over $1 billion, and that's personally in aggregate bets over a long period of time. And I made a lot of money doing this. I haven't been right every single time, but I think people on Wall Street who are professionals know my reputation. Earlier, I saw somebody in here who's a top Wall Street hedge fund manager who's maybe the only couple of people on Wall Street who I point to as maybe even better. And, this is not like within the realm of even possibility. So I'm just sort of talking about my track record for a second, but let me talk about the arguments. So the strongest argument I would say is the lack of clinical effectiveness. So you cannot cherry pick data. And I think can you just go on mute real quick because I'm getting a lot of feedback from your side. Thank you. So I think you're smart enough to know that if you look at a distribution of data that you cannot simply decide that you like one part or one half of the distribution and that you don't like the other half, and that therefore the half that looked better for you, you're going to stick to that half. It's kind of capricious, right? It's sort of like...
I'm actually, as I said, right, I'm completely ignoring the phase 2B. I don't care whether it's success or failure. Because that doesn't add any weightage, right? If you are like saying, okay,
hold on.
completely by phase 2B, I completely agree, right?
Let me interrupt you for a second. Okay. If you don't have clinical efficacy, how do you bet on a clinical trial result being successful?
Totally. So that's why, like, they did the Conrex redid the analysis, and we can argue, but it's only on a 28-day.
That's not clinical outcome, right?
Mm-hmm.
The clinical outcome.
So, if I understand correctly, you're saying it's like that 28-day study. That is what was most important here, right?
Both the 28 days, which the SEC showed us that. Mm-hmm. If you read, I don't know if you read the SEC lawsuit, but
yes, I did.
They showed that the drug actually was not working, and then after she changed the data and manipulated it, it was working. And she never told us that she changed and manipulated the data, so that's that trial that did not do well. And then the controlled withdrawal trial did not do well either. That's where the whole mild, moderate kind of attempt to respin the data applies. So those are the two pieces of clinical evidence. Then there's the biomarkers, which is not clinical outcomes evidence of Alzheimer's. It's just measurements of fluid. And then there's the preclinical, which is even further away. That's just playing around with lab tools and mice and stuff. But there's huge data that's important in prognosticating this is clinical outcomes. Did the people get better or not? And in 2 phase 2 randomized controlled trials, they both showed no effect.
But the second study was completely it's a withdrawal study. So I get your point. If right here, Cassava's argument is it's a the patients were on simufilm, and if their mechanism of action is correct, then you will agree, right? Those patients actually had it's a disease-modifying drug.
Well, hold on. Mm-hmm. So when you give a drug and you take it away, the effect should go away.
Is it, if it's a disease-modifying, do you
No, I don't think it matters.
Does it matter?
I've never seen that in my career. If you can point to me another drug where you can stop taking it and the drug keeps going, it keeps working even though it's not in your body, I would love to see that. And
here they're saying it's like they're fixing the misfolded filament, right? And then
if you take the drug away, it'll fold back into its original shape. Theoretically.
Is it immediate?
Yeah, it's thermodynamics.
That's where I was having that debate with ChatGPT, and it's not like that, right? You have more experience. This is as I say, right? I'm not a biotech investor, so.
Well, I would say this,
convince me or make a good argument so I can go put in the.
No, that's fine, and I'm not an impolite person until somebody is impolite with me. So I totally respect the way you're coming at this. But here's one more thing to think about is in folding proteins, which, by the way, very, 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 very few drugs work this way. Like the amount of drugs that work by refolding a protein is exquisitely small. It's like 2 or 3 out of 1,300 novel molecules approved. And they did not really design this drug to refold. And there's no publication of their chemistry. To make a refolding drug, like the big one that I'm familiar with is Vertex's drug. The Vertex clinical trial, the Vertex team that did this, I actually hired 3 of them way back when I was the CEO of a drug company. It is extremely difficult and almost a miracle that they got this drug to work. And they got to publish over and over again dramatic results of preclinical work in journals like JMedChem and other sophisticated journals. This never happened, and Dr. Wang is not even a chemist. They don't have a chemistry team at all at Cassava. So like this whole thing is a little bit mysterious how they're able to do this. There's no crystal structure. In drug industry, this is like in software engineering, like having a version control. This is like elemental. Like there's no crystal structure.
So if I understand correctly, like you're saying like the placebo, even though they had a drug like a disease modifying drug, they will immediately be back into that like same placebo kind of
Yeah, I
situation.
think that's correct. I mean, I think this whole disease modifying thing is very suspicious. So again, I would encourage you to,
if it's a fraud, right? This is my own conclusion. Either it's a fraud or it works. So if I believe, right, if it's a fraud argument, then yeah, you're right. This is everything. All these things are sham. I'm wasting my money. But if if the other side is correct, it's a disease modifying, then I don't get it, right? It's like
well, why,
the placebo.
if it was disease modifying, there would be a big difference. The controlled trial would have worked. So if, for example, in that 6-month period with drug versus placebo, we know that in this drug that the p-value is not statistically significant, that the trial failed.
Yeah, because the placebo didn't decline like as you expect, like a normal placebo, like on a mild or medium will decline, right? Because the bull argument
but
is.
hold on, the moderate patients were declining rapidly.
That's true. I think it's the mild. That's where the.
Well, why didn't they know this ahead of time? You know, to me, they saw the data and they said,
if it was successful, we would all be, right? I won't be investing it. It would have already be valued, like, right? I don't know, like 500, whatever it is. Right now, there are a lot of questions, and we have a good.
Well, hold on. I cannot find a professional biopharma investor who is bullish on Cassava. So there are people like me, and I'm just one of thousands who get paid, who at least at one point in my career got paid for a living to look at drug companies and decide how to take pension funds and wealthy individuals and invest in biotech for them for a fee. And those funds are very large and very well known. There's Baker Brothers, there's Eco R1, and it goes all the way down. There's like 50 of these funds that have $1 billion or more.
I don't know, Martin. I don't give it like much weightage because I was with Tesla and like most of the Wall Street was against them when they were like trying to scale and like it will never work. It's so easy.
But there were some people. Bailey Gifford was very bullish on Tesla. Many other firms, but I can't find a single person who likes Cassava. And when you add that to all this other stuff I'm talking about, it's...
Okay. I want to discuss one more thing. Okay, I get it. Okay, I give some weightage for that too. Okay, there is enough scientific evidence and scientific backing from other reputed people, right? That's a good point. That's why ChatGPT was not giving it the highest rating because one was like the 98% failure ratio. And
that's right. 98%
yes.
Off the bat. Then you have every Wall Streeter saying, no way, I'm willing to pay 100% APR to short the stock. That's how convinced I am. And then you have the CEO has to resign just months before the trial results because the SEC is suing them for fraud. You have the scientists getting arrested.
I mean, it's so common. I don't. I mean, even Musk got like fined. This stuff, like it's you know, if you know SEC, they will come up with any charge and they will try to settle it.
This stuff does not happen normally. I've never heard of a drug executive getting indicted for faking trial or for faking.
The problem is, if I am objective, I can't give that a weightage in my analysis, right? Like I'm taking this mechanism of action, the open label study, the phase 2B study. Those are the things I'm giving like a weightage on, right? Okay, there was a settlement. We don't know for sure whether it was good or bad, right? Whether they actually did, we don't have any proof on that. So, okay, if you want to make an argument that they are actually fraud, yes, good.
Well, hold on. If you see the Western blot, the experiment was done, you can see in the Photoshop that he flipped the image and then stretched the image. And so, like, I don't think the accusation that the government is making, and I've had my own trouble with the U.S. government, I don't think the accusation they're making could possibly be wrong because you can see his fraud right there. It's like
so tell me then how is
it's as
like,
if I mean, it's as if he
Yeah,
drew a pic. Okay, go ahead.
I agree. Let's say, then how does he manipulate that TR Fred assays? Like that both needs to match, right? But they didn't say, okay, yeah, he did also manipulated the TR Fred. Why didn't they do that?
So the Fred assay is not meaningful. So what anybody would normally want to see here is a crystal structure. That this drug actually binds its target. A crystal structure is about $50,000. It does not cost a lot of money to take a crystal and say, here is where my drug makes a binding to this protein. And they never did that. That's the experiment everyone wants to see. And this is fundamental.
This is a $1 billion company. So it's like, and they're still trying to figure out, right? So if it works, that's how you will see more proof on all this mechanism of action.
No, you have to do that experiment before you invest. As a person who's made $1 billion drug company himself, this is like the first thing you do before you start investing tens of millions. You want to say, does my drug actually interact with this protein?
Yeah, I was reading this, the Western blot, it's very error prone, right? This is, you have more experience on that. I don't have any experience, but this is what I get from my research. It depends on a lot of how you load the data. It's very error prone. And I read like a lot of other researchers were also into trouble because either it was like, the Western blot is not correct. There is a lot of studies, and that doesn't mean all those researchers are fraud.
Well, the Western blot is just one tool, and it doesn't really speak to the drug side of it. It's just on the protein side. So it's a tool to interrogate biology, whereas on the drug side, on the chemistry side, you want to know that your drug is sticking to the protein. And without a crystal structure or some other unambiguous kind of like, the crystal structure is nice because it's like literally a photograph. It's like, I have the culprit. I caught him red-handed. He's binding to the drug at this exact spot. And then the chemists use that molecular information to say, okay, let me add a fluorine here. Let me add a methyl group here. Let me add it would be really good if there was a benzene right here. It would work out really well for space filling or for PK or for any adjustments. And then you publish it. And they've never done that. And if you look at who did the chemistry for this, it's two people on a patent that was outsourced. And it's very weird to me how this drug came to be. And again, it's not common for a scientist to get arrested. If it happened every day, it happens every day in hedge funds. But I've never really heard of this. And the Western blots you can see were just copy, paste, invert, stretch, Photoshops where it was like, dude, you obviously made this up. And if he's making up the Western blots and you have Dr. Burns making up the phase 2 data, according to the SEC, what else are they making up? Like,
I would have been more convinced, right? If it was, what will be their motive? To just get some research fund and then continue the research? That sounds so like for Burns and Remy, right? What
I think it's embarrassing.
Just to get a few more years on their company?
Yeah. I mean, they did this. So I met Remy 20 years ago, and he was my boss's college roommate. And he had 3 pain drugs. The company was called Pain Therapeutics. And they all failed. And he was the laughingstock of Wall Street in pharma. And then he gets Simifalam. And then it fails again. And his ego says, I cannot be the laughingstock again. This is too much. Everything I do has failed in pharma. 25 years of my life trying to run this company is a 0.
But why would, okay, I get you, if I take your argument, if he goes to phase 3, if the drug doesn't work, it will fail spectacularly. He will be a laughing stock, right? What is he trying to achieve by extending these trials? I mean, if he was selling all his stocks along the way and making a lot of money, I wouldn't have been in this.
I think it's self-delusion. I think it's, they looked at the phase 2 and said, how can we can't accept another loss. And it's this mental blindness of like, how do we make this like, look good, or it's really successful if you look at it this way, it actually worked out. And it's a lack of objectivity. Sometimes in my own work, I look at something, I make something, and I say, isn't this great? Maybe it's a piece of code. And I show it to my colleague, and they say, oh no, this is actually worse than the reference standard algorithm is much better. you just wasted a bunch of time here, just use this, and I feel stupid. And sometimes in those situations, you'll say, no, I'm right, look at this. And it's very embarrassing to say, shit, I got it all wrong. and I messed this up. And he rebranded the whole company to Cassava on this
Yeah,
one
I
drug.
can buy all those things. I mean, but why? If he knows the drug doesn't work, why take all this pain and go through like 2 phase 3 trials, and then he will be like biggest laughing stock.
I think
He should be
some
like,
people,
okay, if he is a smart person, he should be like selling all the stocks when it's high, taking all the money out, and then
well, he's getting a
enjoy.
salary.
What's that?
He's getting a salary. He's getting a bonus. He's
That
getting,
I mean, I don't know.
listen, it's not nothing. And he's getting the ego fulfillment of being in charge. He buys this big building, right? Wastes the shareholders' money buying this big building. He employs his wife. His whole family's tied up in this now. So I think when things got bad, he just sort of said, maybe I like to just interpret it a different way. And of course, I don't think he planned on defrauding the phase 3. I think if the phase 3 failed, he would have said, all right, look, it didn't work out. That's how biotech is. I'm going to keep going. I don't think he's a bad guy. But I think the phase 2 was just kind of like generous interpretation.
Hey, okay. So I have another question. Like, did you read that? Like, they did the analysis and on the biomarker, they said like the AB42 increased by 74%. Did you read that? I don't know if like it was on one of the phase 2 studies, and there was no questions by anybody on that. But recently, Dr. Epse and his team, there was a report that came up from them that saying like the Alzheimer's cognitive stabilization is due to the increase in AB42. The MAB drugs, some of them actually helped increase AB42. That's why there is a cognitive stabilization. I felt that was a compelling argument, and there were like no short arguments saying that okay, that biomarker data is not right. If the AB42, like they're saying, like it's increased by 74%, and then now a report come up like the AB42 is a uh, major factor in stabilizing the cognitive decline. I think that's huge. What do you have to say about that?
A couple different things. So one, I don't really trust anything from this company. And then two, the weight of biomarker data when you already have available clinical data, you would weigh the biomarker data basically as meaningless compared to the gravity. It's not meaningless in a vacuum, but to the gravity of clinical data, I would say it's meaningless. And then I would say just about the biomarkers themselves, like you need a plausible reason to believe that this drug would interact with physiologically to change biomarkers in the first place, which, you can't get a drug approved. You cannot get a drug approved on biomarkers. So to me, it's just kind of like hard to understand it. And then if it worked so well, you would have seen it in the medium or the moderate patients. And the moderate patients did terribly. They weren't getting disease modifying.
Yeah, I mean, to get the drug approved, right? They have it. They are doing the study on both mild and moderate separately, so they just need to get it done on any one of those groups. So,
But if they
yeah,
believe
there is. I get your point. That's right.
if they believed the mild moderate difference was real, they could have just made the drug mild only.
No, they are. It's what I understood is like it's stratified, and they are doing two control group studies. There is mild and moderate.
No,
So there's
moderate
one
is in.
trial, but it is it's divided in two subgroups. So
Why would you do any moderate if your drug doesn't work in moderate? We know the drug doesn't
because
work in moderate.
they think it might work. So what is
It
wrong?
didn't work in phase 2.
I mean, what is that? Are you making an argument saying that they are, if it doesn't work in moderate, the drug is not effective, or like
No, I'm
you're
saying
saying
that if
like those subgroups are not correct, or
you do the reason you do a phase 2 trial is to see if you want to pursue a phase 3, which is long and expensive. Mm-hmm. So they did a phase 2 trial, and of course I don't think the drug works at all, but their story, their narrative is that it works in mild. Okay, if you believe that, just do a trial of mild. In fact, I would do extreme mild. I would not even think about a patient that was moderate or even towards the moderate end of mild. I would go so early in Alzheimer's disease they barely had it. But instead they said, we'll take moderates too, whatever. It's like, wait, you just told me that it doesn't work in moderates, but it works in mild. Why are you taking moderates in the trial?
Okay, yeah, that's an interesting point. But what I understood is the trial is it's stratified. It's two different groups.
You
As
can
long
always
as you get
stratify, but
stat significant in any one of the group, you're good. If you are
no
good on one,
way. You need to meet stat sig in the entire population.
okay, that's not what I understood.
No. I've done clinical trials for a long time, and I concede if they meet stat sig, it'll be a $1,000 stock. But you cannot say, unless you say, you have to define one primary endpoint. You have to say, and in statistics, I'm sure at some point you probably took a class in statistics, a lot of people have forgotten it, but you have alpha spend. You have one alpha spend of 0.05. You can split it into two primary endpoints, but now your alpha is 0.025 for each. You can do a hierarchical statistical analysis where you say, after my primary endpoint, I carry over my alpha and I preserve my full alpha to the next endpoint. But you cannot say my primary endpoint is all comers, mild and moderate, and
they didn't say that, right? It's like they have two.
Well, they don't
groups.
even we don't know what their statistical analysis plan is because they haven't even gotten it from FDA.
If they are smart, they will do that, right? They will say, okay, yeah, we are doing it separately and combinedly, and then
sure. So they say, tell the FDA the moderate is not part of our trial. Cool, they can do that. I still believe it.
They are saying like, okay, we are testing.
But not part. When I say that, just be clear, not part of our primary endpoint.
Okay.
Because why would you want?
Correct, right? I don't know.
It's very hard to meet statistical significance anyway. So why would you poison yourself by saying our primary endpoint is ADAS-Cog change versus placebo from baseline against all comers? I would just say it's against mild only, and we can do another secondary endpoint after the fact for a different endpoint after the primary endpoint. But you get one chance on the primary endpoint. And everyone will tell you, if you fail primary endpoint, you got to do your trial all over again.
Yeah, but we don't know how is the statistic SAP, right? It could be into different groups, so we can argue, but we don't know how it. And there are drugs which are approved if it's working on one subgroup, as long as it's there on the SAP, right? It's not
as long as it's their primary endpoint. I don't think there's been any drugs where you can throw out half the patients that didn't work and say, oh no, it works in these patients, so just to prove it in these patients. FDA doesn't work that way. You have to specify beforehand which is your primary endpoint, and you have to meet it. You can't say, I'm going to try it all, and then whatever endpoint hits, I will just get approval for that.
Let me repeat what you said. So you're saying is like they for this drug, even though they cannot say it is like it works only on mild or only on moderate. And what is your reasoning for that? Because even if they say that, okay, this is our SAP and we are going to do subgroup analysis for this, it doesn't matter. That's you're saying is like it needs to be for the entire patient population. That's on the study.
You must specify a priori before the results, a priori a primary endpoint with how much alpha you want to spend on the primary endpoint. You can specify 2 or 3 primary endpoints, but you must split the alpha between them.
So can they do in the SAP say that, okay, this is my primary endpoint on mild, and this is my primary endpoint on moderate, and this is my primary endpoint on combined? Can they do like that?
Yeah, you can. So what you would have to do in that case, and keep in mind that if you fail one of them, it'll be very weird that your drug worked in these people but not these people, but it's plausible. I think the FDA would say, hey, there's a way to do this. You can do 2 different trials, right? Why put them all in one trial if you didn't mean to enroll milds or moderates? Just, you should have done one trial with milds and one trial with moderates.
Yeah, I can take that argument. Yeah, but they could have done like the rethink and refocus on like that. Like they could have done two different studies on one for mild and one for moderate. I
Yeah,
don't know why
that's
they
the way
didn't
they
do that.
should have done it. But irrespective, you could say that our co-primary endpoints are mild and moderate. But typically with co-primaries, you actually have to hit both. If you fail one co-primary, you fail the entire analysis.
I
So
mean, for me, if I'm an Alzheimer's patient and there is a proof that works on mild,
that's not proof
uh,
though.
yeah, I mean, yeah, as long as they can, like, they have it in the SAP, right? It's not a
Yeah,
post.
you have to say ahead of
Yeah.
time.
I hope they are smart enough to say that.
Well,
Uh,
I think that the best chance they would have is just say our primary endpoint is mild patients only. We are not statistically going to even look at the moderates because they failed in phase 2. So why would we look at it in phase 3?
I mean, it
And
depends on how you look at it. That's where, like, for them, all right, they are thinking it's a disease modifying. It works on both mild and
but
moderate. It might, right? I get your argument. This is completely a fraud. It doesn't mean, it doesn't work. It's not going to work on anybody, right? Uh, yeah. I think this is an interesting, I see an odd on this based on, like, I put all your, these arguments, right? I think mostly I knew,
well,
like,
let me ask you another question, just to go a completely different direction.
sure.
How many biotech trials like this have you looked at in your life?
As I was saying, this is my first one,
No,
and I'm relying
that's fine.
completely on ChatGPT and, like, on all. I compared it with all the map
Have you
studies and all, right?
have you ever
So,
played poker or any other
oh
game
yeah,
like
I
that?
love poker. That's
Yeah,
why
so
I
like
like my odds here.
when you play, I play a lot of poker too. When you played your first hand of poker, were you as good as the one that you're playing now?
No, this I swear. When I learned, like, I'm studying more, I'm feeling more convinced. Like, I have pocket aces, and I'm saying, I should be betting more. That's the kind of feeling. I'm like restraining myself.
But
Don't put more money on it.
over time, you got more skilled as you played more poker hands. You learned more about the game. You got a little bit better at it. Your first poker match was probably terrible. Same thing in chess. The first time you learned how to play chess, you weren't that great. This is your first ever binary event. My first one was in 2001, 23 years ago. I mean, I think it's just prudent to bet a small amount, learn, and if you are good at binary events, and you're right, the next time you do one of these, and there will be many more to come over the next 20 years, big drugs with big binary events, you can make a big bet then. But why with your first one would you?
Yeah, I'm not betting my house on it. Okay, I will be disappointed if it doesn't work, but yeah, I mean, the life goes on. It's not like I'm putting all my wealth on this stock. It's like,
I think other
but it's a
people are.
substantial. I have like more than 10,000 in stocks and options on it, but it's not like
No, I understand that
not
everyone has to
huge.
make their own choice, but I just
Yeah.
think every time, the first time I played chess, first time I played basketball, you should see how I was throwing the basketball. I was the worst looking basketball player ever, and then I ended up playing really well because I trained really hard and got better at it, and this is no different from any of those. I mean, if it's your first time ever looking at a clinical trial, you will
Right.
learn. One of the things I learned is that open label data is meaningless and useless. That without a control group, you will never be able to determine how a drug worked, and that you value the control group data 100x more powerfully than the uncontrolled data. The next thing I learned is patient and doctor testimonies mean absolutely nothing. I mean, I've had doctors tell me, Martin, I've never seen a drug like this. It's amazing. I can't believe how well it did, and it's no different from placebo.
So, do you think, like, the people, like, that, like, they're saying, like, there are 200 patients, right, on the open label, and they had, like, the cognition stable for 24 months. That is like, I mean,
Only mild
how
patients.
do you
Only mild patients. Only mild patients.
yeah, how do you define, like,
That's not yeah. Hold on. You're just saying yeah. That's a big
Mhm.
deal. You're
Yeah,
throwing out half the people.
what's that?
You're throwing out the worst half and saying the best half is looking good. Why are you
No, in the
surprised?
mild,
Yeah,
can
in the
you?
best. Hold on. You're basically saying in the fastest runners they ran fast. It doesn't make sense. It would be impressive if all of the patients were stable. That'd be amazing.
Yeah, help me understand this, Martin. Like, is there any study or how you manipulate this? Like, you take some mild Alzheimer's patients and give them this drug for 24, any drug, for 24 months. Can you stabilize their ADAS-Cog score?
Yes. Selection bias. That's why there's a control group.
Yeah, I was arguing with ChatGPT on that.
Rater bias.
There is a placebo effect. There is selection bias. There is like all different sort of things.
Rater
But
observer bias. I mean, all these.
nothing lasts for 24 months.
Sure, I could
If
just
they,
tell.
unless like,
But you're only looking at half the data.
what do you mean by half the data? I didn't
That
get
you're
that.
only looking at mild. What happened to
Yeah.
moderate?
Tell me, like, can you stabilize, even if you just take mild,
No,
how
you
do
can't
you,
do
like,
that. You're saying
using the selection bias, like on an ADAS?
the answer is yes, but you cannot simply take the better half and say, look how good this better half is doing. I'm going to ignore the worst half. Do you think that there's a drug? Let me ask you this. Do you think there's a drug where if I answer a question right on the Alzheimer's test, the ADAS-Cog test, and there's a line where after 24 points, my drug doesn't work at all, but at 24 points and below, it works really, really well. Does that make sense to you?
I mean, it would have different effect on mild and moderate. I feel like
Not
it's like
really.
a cancer. Like, for example, if you take cancer, what I understood is you have different stages, and your drug or whatever treatment you do, it depends on like how early you detect and like treat, right?
Some drugs work that way
Yeah.
these days,
So
like
why can't this
Keytruda.
be like that?
Well, Keytruda, almost every drug in medicine does not work that way. Almost every drug in medicine, no matter how severe you are, it will help you. Cancer is a weird exception to the rule, but it's an exception. All the other drugs that I'm aware of, if you have a little bit of allergies and you take an allergy pill, you will get relief. If you have a lot of allergies and you take an allergy pill, you will get relief. If you have pain and you have really severe pain, opioids will help you. If you have a little bit of pain, opioids will help you. Almost every medicine works this way. And here, they're saying there's a magic light switch. And this is if you already believe and trust the data in the first place, which I do not because it has not been published in any journal whatsoever. At least Tesla, look, people were skeptical, but they had revenue, and they had patents, and they had like some amount of official stuff. And they had some shareholders. It was a minority, you're right. But Bailey Gifford was very bullish on Tesla, many other smart people. So here, they've never published this data because therefore I don't think you can even trust it. But even if you take what they say at face value, they're basically saying after MMSE score of 24, if you're 25, drug won't work for you at all. But if you're 23, it's a magic pill. Come on.
It's 10 to, right on the mild, for the 10 to 20 and like,
But does it make
I
sense
don't
that
know.
19 works, but 21 is failing?
For me, it makes sense because it's two class. It's like I will compare like a cancer, like early or like you're late, and in this case, like you're mild, you have like
Well, actually, for many cancers, that whole idea that like mild and moderate is different is now gone. Like Keytruda works for all cancer patients, mild or last stage, early adjuvant, like before they even spread tumors. It stops the tumor from spreading, and even after they have metastatic disease, it works. So not every cancer drug works that way. So basically, you're looking at to explain this drug, you have to jump through so many hoops. You have to say that I'm going to pick the one disease where medicine doesn't work this way. Out of 99% of the surface area of medicine, mild, moderate doesn't make a difference. But there is 1% of surface area of medicine where, yes, the stage of the disease matters. And you have to pick that 1% for this narrative to make sense. And then you have to also believe that the guy getting arrested, the SEC stuff, all of that doesn't make sense. Then you also have to believe that filamin is a logical protein in this situation, which it is not, in my opinion. Then you have to believe that the mild-moderate distinction is relevant. So, I mean, to me, it's just too many hoops to jump through to, like, the simplest answer is the drug just doesn't work.
Yeah, I can see your argument, right? You can say, okay, yeah, it's completely, the MOA is completely fraud. They cooked up the whole thing. The phase 2 bits cherry picked. It doesn't work, and then they manipulated like the whole oily, right? You can definitely make a case for like this completely doesn't work. But if you look through it, I see a lot of other data points that says it works. Do you see any
Now, this is
do
also
you
your
see any
first,
data points where it works?
no,
Let me
I
ask
don't
you.
actually.
You
I
don't?
do not. And this is also your first rodeo, right? Like, if
Yeah,
you,
this is might be my first and last. I mean,
it
I see
might be your
the
last,
rewards.
exactly. I hope you make money, first of all, because I don't want anyone to lose money. But
I
I
mean,
think,
on the biotech world, I don't understand the biotech, but I'm just going
I,
through ChatGPT. This is my experiment, right? Let's
so,
go through ChatGPT. Let's
no,
give
it's
prompts.
honestly
Let's see how it works.
smart thing to ask ChatGPT. I spend a lot of time in LLMs and in
Yeah.
PyTorch making models. It's very useful. But 21 years I've been publicly shorting stocks. And each time I do this, I meet somebody like you who's very smart, very successful in their competency. And they say, what about this? Does this work? And I say, no, you're really, you're kind of barking up the wrong tree. This isn't going to work. And they say, well, I'm so smart in these other areas. I'm smart in this area. And they try it and they're wrong. And they say, never again. I'm never going to do this again. So
I
that's
mean,
called, hold
I
on, let me
need to
finish, let
have
me
a
finish, let me
story
finish.
to tell to
Let me
my
finish, let me
grandkids.
finish, let me finish. Let me finish.
Yes.
That
Right.
is called gambling. If you want to get a proficiency, a serious proficiency in this field, you would chart a 10-year course where you say, I'm going to bet 0.5% of my capital on this. Because guess what? Cassava is not unique. There's 2,000 publicly traded biotechs. They will all have binary events that will go up 10x, 20x, 50x, etc. Many of them will go down 99%. You can make money on shorting too. And next trade, if you got the first trade right, great. Next trade, you put 1% of your portfolio. Next trade, 2%. Next trade, 5%. And you will develop this proficiency. But that's not really... Tell me this. If the stock goes down 99%, which is possible, will you never look at biotech again?
I mean, most likely, unless I see another sour, which can 50x, and I go through it, and I feel like, oh yeah, this looks like a good odds for me. At this point, I mean, I will go back and put your points and then see, does it change my weightage? Even if it's 20%, 30% odd, I mean, it works. But yeah, I get you. If it's
Okay.
one of the arguments that ChatGPT was saying is if you're a scientist, if you're rely on go by just the hard data, right? It is not a good, it doesn't look good. I
Right.
totally agree.
Well,
Because
let me let some
there
other...
is a lot of allegations and all these things, right?
You can email me anytime you want, martin@dl.software. I don't have any weird conflicts of interest or any personal vendettas here. So I want to let Florida Joe chime in if he wants. And it was a pleasure talking to you.
Thanks, Marty. I appreciate it, man.
Sure, and you can hang around if you want, but I just
Yes.
want to give other people a chance.
Yep.
Hey, Martin. Great conversation.
Thanks. What would you like to talk about?
Honestly, no, I just came up to say, thank you for Mr. Anish's time. And no, it was a good conversation. That's all.
Okay, great. Rob, do you have anything you want to add? I've been at this for a few hours, so I just want to check everyone and see if they have anything to add, and then I'm so happy somebody came up to discuss it, and I don't think I was rude or I didn't make any personal attacks to you, or I was as respectful as I could be, and I did with the same thing with Matt Nacktrab. I was very polite. I said, very complimentary things. But if somebody attacks me, I will attack them back. Rob, do you have anything to say? Okay, Andrew. Let's try this guy, Andrew, see if he can add something to the mix. Andrew. 99.5%, probably higher.
So what's the best way to trade it? You think puts, shorting?
I think you sell calls, because then you don't have to, if they delay the results, you don't have to worry about that. And if the stock only goes down 20%, you don't have to worry about that either. You also don't pay borrow costs, at least directly. Then I would short the stock. I think buying puts is okay too, but you are taking time risk and directional risk. So again, I would encourage people to think about the likelihood of this drug working is as similar of an engineering miracle as the Tesla rocket landing right side up on a dock. It's like drugs don't work by accident. They have to work. Everything has to make sense. Everything has to come together pitched perfectly by hundreds of scientists that work very hard. And this thing is just not that. None of the signs show that it's going to work. None of the, evidence lines up to that. It doesn't look like any drug that I know that ended up working. So to me, people think maybe there's a chance because God knows we're just flipping a coin, right? Maybe it'll flip heads 3 times in a row. No, that is not how these work. And that's why people think of the risk reward. They think of it as, well, if it does work, it goes up 50x. And there's only 2 possibilities. It might work, it might not work. Even if there's a 10% chance, it might work and I make 50x. Okay, but is it a 10% chance? How do you know it's not a 1% chance? Or a 0.1% chance? Or a 0.001% chance? If I picked a random molecule from the chemical search space, it has you at this point need scientific notation. It's like 10e to the negative 10 that it would work. So, it's more likely that that's the probability than any, probability that can be expressed in a percentage.
The premiums are expensive. What month do you think it comes out? December or January?
I don't know, and I can't guarantee it, right? They could actually delay the data. They may see the data and see that it's bad and they want the other trial to read out first. They may just, who knows what will happen. So they've said by year end, and I think most of the bulls believe by year end, but, I always try to be careful. If you're only long puts, you're running into a few issues. You do have limited downside, which is great. That's the big advantage of being long a put. But you have to get the timing exactly right, and you don't benefit much. Some of the break-evens on those puts are it can go down 50% and you break even, which is doesn't feel good if that happens, right? So
yeah, that's why it's the timing,
Yeah, well, you can get a mix of shorting calls, short a call spread. There's a lot of ways to sort of be happy here without, let's say you sell the 50 calls and buy the 55s, right? You are limited risk and you get paid out if it fails or gets delayed, and you don't get paid out only if it goes to 100 or something. And there's limited risk. So there's a couple ways to construct a trade here. I'm so confident, I don't even think it matters. Shorting the stock is fine, selling calls is fine, buying puts is fine. But you can get burned on those puts, especially as you get more out of the money to 5, 10, 15 puts, 7.5 puts. Those are risky. They can make up some bullshit. They get very nice people like Anish to believe it because they're new to biotech. But these subgroups are the end of the world. Open label data is the worst thing in biotech. Time and time again. Everyone hears, oh man, those patients did so great. Then the control trial comes and they didn't do so great. They didn't do any better than placebo. It's amazing how these things can fool you. And again, I'm not saying it trying to dunk on anybody. I've just seen it so many times over and over and over again for so many years. The control trial is really all you can trust unless it's a complete miracle, tumor disappears or something like that. And there's no such miracle here. This is very normal, and you should see some separation from placebo. The only time I would look at open label data is if there is no placebo control data. If there is placebo control data, open label data is completely worthless because you just look at the placebo control data. Even in some trials, you only need 10 people to see placebo control data. I remember one trial with Alexion. This is a drug called eculizumab, and it was for PNH, paroxysmal nocturnal hemoglobinuria, a disease where you pee this rich red color. It's like Coca-Cola color. You know something's wrong with you. And they had 7 people who their pee went from red to yellow. And they said, we didn't need a placebo group for this. We've never seen anything like this. And even with 7 patients, they had statistical significance. So to me, you need a result like that before you can really say, I don't really care about a control group. But you always need a control group in medicine and in science. It's doesn't make sense when you have control group data to ignore it. So on the shorting stuff, you could find the risk reward profile that works for you. You're all professionals.
Yeah, well, with cancer, sometimes you used to say, it works on this subgroup, it's such and such a gene or whatever it is, and they use that kind of scam. But
Yeah.
I don't think there's anything you can do with this Alzheimer's. What are you going to say? I mean, there's no genetic stereotyping, right?
There is a little bit with ApoE, but I'm glad you said that because it sounds like you've been through your own bunch of these. And
No,
there was
oh yeah, well, actually I've been following you for a long time too. I can speak to your acumen because I remember there was this stock you had around 2014, 2015. You said this drug ain't going to work. It went from like 16 to 3 in like a day.
Yeah.
You probably know what it was. I can't remember it.
I think that the funniest story ever is probably Bob Duggan, who took over a company called Pharmacyclics. I think it was his wife or maybe his son, I don't remember. A family member close to him passed away from brain cancer. And here's the super rich guy, and he made his money in a bunch of different industries. And he said, I'm going to buy the next biotech that's makes a brain cancer drug. And this company, Pharmacyclics, was doing a subgroup, a redo of a subgroup. Their phase 3 failed, and they saw a subgroup, and they said, let's do the subgroup as the new phase 3. That phase 3 failed. But Bob Duggan turned Pharmacyclics into a $25 billion company and sold the company to AbbVie, and he became a multi-billionaire in the process. Now he has a new company, Summit Therapeutics, which seems like he's repeating the same story. So it was funny that he learned that lesson. He bought 10% of Pharmacyclics when all they had was this cruddy subgroup, analyzed to death kind of drug. Drugs should either pop off the screen and they work. You shouldn't have to explain, technically in mild, we did really well, but on moderate, it didn't do, you shouldn't have to explain it. It either works or it doesn't. And I hope when this phase 3 comes out that they don't try to bullshit and explain and spin and all that. But I wanted to make sure everyone had a chance to bat in. Did you want to jump in, or Andrew?
Yeah. The amount of baggy cope is just insane, I think, they already believe that it works, so they'll come up with anything, oh, well, this isn't right. Well, it's okay because blah, blah, blah.
I don't think so. I think these people are a lot smarter than you give them credit for.
Well, at this point, it's like death by 1,000 paper cuts,
I hear you. I just, if somebody's got it.
There's a lot of fraud in this, these Chinese researchers. It's been, it's not totally unknown for them to manipulate stuff.
Sure.
And I just wanted to know, what else do they have? They don't have anything other than this drug. They have some other things, but it's not really significant. And then, I believe it's going to zero, and I hope they get delisted, honestly.
I'm sure it'll happen, but take a look at the guy who I just spoke with. You got $300,000 in the stock. That's not nothing I got sued by a guy worth $100 million for $100,000, and I got indicted over this, and I made him $800,000, and he still was upset with me. So, this guy is I don't think that rich, but he's got $300,000 in the stock or so. If let's say it fails, and the stock price goes to 15, because they say, if you look at this subgroup, it actually does work. And, it sells off, but it doesn't go to zero. Guys like that are going to say, you know what? I still have 150,000. I'm going to exit. Good luck with this, guys. It's kind of a shit show. And the stock will eventually, if not immediately, drift to 5, because people like that, you're right. All it takes is 80-90% of these people, they're so addicted to this narrative, they're going to stay with it. But as we all know, the last sale price is the deciding factor of what the price of the stock is. So all those people can hold, but all it takes is a smart guy like him or somebody else to say, I've been lied to enough. I'm down a bunch. I'm going to cut my losses here. Maybe have some gains in some other stock I can use as a tax loss. No mas. I'm out. And that marginal trader will eventually knock the price down to the lowest price. And in biotech, it's very rare. In my memory banks, I can't remember too many times a drug failed and it was their only drug and it somehow stayed above water or even dropped only 50%. They drop a lot, because I do think some of these people are smarter than they look, and they do get woken up very quickly. And they stop drinking the Kool-Aid once the press release says, well, we didn't meet the primary endpoint, but if you look at these patients sideways, maybe we met the primary endpoint. And I think there's enough people. It only has to be 5% or 10% of the people, and usually all of them will wake up, but the most diehard people, and they'll wake up and say, I'll take some money off the table here.
So,
Martin,
what do you think?
Just curious. Just curious, how large is your position?
I haven't disclosed it yet, but I'll shed more light on that maybe as time comes.
Oh my God.
Okay.
This is
So what do you
awesome.
think is like the 1, 5, 10-year future for this company? I mean, if assuming this fails, like it's pretty much over.
I think what they do is reverse merge at some point. Usually that's what happens in biotech. But usually that happens when companies have a lot of cash. And in this case, between the payment they made to the SEC and the money they have left, which they'll burn over until the second phase 3 comes out, that's like another year of burn, they won't really have much left. And then they'd have to do a reverse merger with another company. So a privately held drug company will approach them or vice versa and say, we'd like to use the fact that you're public to take our company public. And the merger will be 95-5. And, that'll be that. A company that was very similar was a company called Synta. And I was short Synta. It was SNTA. And there was a very famous investor called Bruce Kovner, who was the largest shareholder. Bruce Kovner was one of the gods of hedge funds. He had a hedge fund called Caxton. And he, like any people who are breathing, he is compassionate about people with cancer. And he said, I'm going to buy a big chunk of this company. I'm going to sit on the board. I'm going to help them make cancer drugs. Well, they didn't make cancer drugs. The company went to zero, and they reverse merged into a company called Madrigal. So Bruce sold all his stock. He's disgusted. He says, I'm never going to touch biotech again. Madrigal ends up being one of the biggest success stories ever, and gets the first drug ever approved for NASH. So really funny how that ended up happening. But the whole, reverse merger thing's common. The Synta shareholders got like 2% of the company, and the Madrigal shareholders got 98%. And you just get diluted down so much that it doesn't even matter if the new thing turns out good, because it's kind of over anyway. So I think that if it fails and they try to do something like that or bring in another drug, like, you're still going to be dealing with like 100 million market cap or something like that. So they can try to fight the good fight and keep trying to build a company, but everyone's trying to do that. There's 1,000 drug companies. They're all trying to succeed. And there's nothing special that these guys have, especially now that Remy and all the talent is gone. Like, this is the same team for 25 years. They haven't been able to succeed now. What is going to make them successful all of a sudden overnight? Any last comments before we run?
Yeah. It's awesome that I'm talking.
Maybe someday Rick Barry will finally succeed.
Sarepta worked out for him, right?
Wait, how much money are you going to make? Do you predict making off this?
It's not going to be as big as my biggest hits, but, we'll see.
All right. Also though, I'm just asking, did you predict when Summit was gonna
No.
pop off?
No, I did not. No.
Okay. Because, dude, I feel like you're so good at this bio stuff, but like the dates, you just get the dates wrong. Cause I was looking at the Biopharma Catalyst and they predicted the date like down to the T, September 9th. And if you had just seen that, I feel like you could have,
Well, probably, but my day job is running a software company.
yeah.
This company, Anoro, just failed tonight as well, which most people in my community thought Anoro, or Alto Neuroscience, ANRO, would fail, and they failed, and the stock's down 60%. And, basically the same thing's going to happen to Cassava. And it's not like some stroke of genius. Like, at the end of the day, like,
Yeah,
with
but
a little bit of experience, you would know that ace beats 2-7, and there's somebody out there saying, no, 2-7 is good. And,
yeah, there's
there's
a bunch of other biopharma companies that are gonna have phase 3 trials on December 31st. That's when they say it's coming out. Like 30 of them at least, tons of them. And a bunch of them are big companies where there's not gonna be a lot of volatility, or they're too small and there won't be a lot of volatility. But I feel like there's gotta be one in there that's like a Summit or like a Scholar Rock. There's gotta be.
I'm also, I think Huma, HUMA is a short, and that's like a really interesting one that a lot of people aren't like crowded in.
Yeah, but I feel like there's got to be one that if you put calls in that Summit or that Scholar Rock, and you knew the date it was releasing, because it's on the internet, but I feel like we could have made a ton of money off that.
Yeah, my day job is not to trade biotech,
but and I heard you're gonna have I'm a Trump supporter. I heard you're gonna have a speech in like Penn State recently.
Yep. I'll be at Penn State. I'll be in Miami as well for Hereticon.
That'll be cool. I love Trump, and the dream team would be amazing. Elon and Vivek
Let's
And,
go.
I mean, Elon wants to get the 50 billion off his tax, but it's cool. It's cool. The only issue though, dude, Alan Lichtman, I would not bet
So
against
I did
him.
the math on that. So what are the odds that somebody gets 10 in a row? 10 elections in a row? It's not nearly as crazy as you think. So it's
Yeah, but
0.05, 0. Yeah.
it's like Renaissance. It's like a weather map.
Not really.
He predicts it with a certain set
No.
of rules that
I
have,
don't think it matters because
but they predicted
it's
every
only,
election since the
that's not much
1800s.
though. Oh,
Okay.
well, he's bet, the name is that he's done 10, right? And the 10 that he's done, it's really not that big of a deal. It's 1 out of 1,000 that you get 10 in a row because they're basically coin flips. So just do 2 to the 10th power. It's 1,024. So 1 over 1,024. There are a lot of people in America. There should be 300,000 Americans that can predict 10 presidential elections in a row. So don't be surprised if 11's wrong or whatever. I think you just look at the polls, try to make some common sense of it. It's definitely a gamble.
Yeah,
I'm not advocating that
if
one person
there
will
were
win or
people
the
that were
other.
asking about they needed quick money, I mean, if you bet on Kamala and the interactive
3x.
brokers, yeah, you're gonna make a lot of money.
Quick
So
3x. Yeah,
13 days, you can
maybe.
make a lot of money. Yeah.
That's not a bet I'm certain on. So
Yeah.
anyway, anybody else?
Hey,
Martin,
Martin,
I,
what other big fails do you see coming this quarter or next quarter from a data perspective?
I
Any
think
other big ones?
Yeah, not big like this, but Humasite, Numora, obviously Alto just failed today. Celas is a small one. I think Humasite's like kind of almost as good as Cassava, to be honest, but that's an FDA approval.
But it's only 5. It's only like you could only make $5, I thought.
Look, I mean, I like making money regardless. It's a $5 stock, but it's going to go down a lot really
that
soon.
That website says the phase 3 is on the, it's like 4 days from now. That's not true.
They were supposed to have FDA approval a month ago, and the FDA told them they need more time. And they're trying to sell this like flimsy little protein-based graft, but they're plastic grafts for $1,000 that do fine. And they're trying to sell this thing for $25,000. And for some reason, they're regulated by the pharma side of the FDA, not the medtech side. And they never did a trial. They actually never did a trial comparing their graft, which is made from biotechnology, byproduct. It's protein-based graft, which is very flimsy, by the way. Plastic doesn't degrade, for better or worse. In this case, better. But the cellular-based ones do degrade, and you don't want a graft that's just going to all of a sudden explode. So basically, these guys are trying to sneak a fast one through FDA, and I think the FDA is going to say no. But even if they say yes, there's no real commercial opportunity for this product. So it's like a really good short regardless. Even if the FDA says we're approved, the next quarter of revenue and the next quarter after that are going to be like measured in thousands, not millions. So I'm pretty excited about Huma just generically as a great short. I don't have time to do like every single one of these, but like Numora looks like a gigantic failure coming up. So we'll see how that goes. But I have to when I short something, I go so deep in the diligence where I'm like, I cannot possibly be wrong because I can't afford it. If the upside is 10x, I'm going to owe the bank money.
Yeah, but do you ever want to buy calls? Do you ever want to, because the shorting it's so expensive for, Sava, and I would short for January 17 because
it's easier to tell,
puts, the puts are expensive.
It's easier to tell if something's a huge steaming pile of dog crap. You can smell it, you can see it. Everyone's avoiding it. But the diamond in the ground that's very hidden, that's buried underneath, some leaves or some grass, that one's hard to spot. And I look for those too. Don't get me wrong. I like a bunch of different stocks like Adma and others, but you can make money on both sides. I make money long side too. I mean, it's not.
Did you know at all about Summit? And there was another one that popped off like the same date, I'm pretty sure. VRDN.
Yeah, I knew a little bit about both, but to have conviction, you have to look at all 400 or 500 stocks. And for that, I mean, you need a team of analysts. Even with a full team of biotech analysts, they're still not guaranteed to do it right. So it's a tough game. It's just like any other investment sector.
But anyway. At that time period, I forget when it was September 9th. That was the only phase 3 that was being released at that time period.
Okay. I gotta
Yeah.
go. Anybody else?
All right.
Last thing.
All right, last thing. What do you think makes a good biopharma investor? Like, what's the most important thing?
Oh gosh. Experience. I think experience helps a lot. Like a lot of the people I know that have made a ton of money in this space, they just stuck it out over 20 or 30 years. I think that's super important. I think skepticism. Most drugs will not work. You have to be really skeptical and really kind of shrewd to not believe the bullshit. There's a lot of industry bullshit. I think a decent knowledge, you don't have to be crazy, but a decent knowledge of medicine and pharmacology doesn't hurt. You know, this is a field of science, so you have to get comfortable with the science and learn it. But other than that, I think it's not nearly as hard as people give it credit for. Usually they look at it and say, oh my gosh, it's so complicated, I'm not a doctor, etc. It's really not that bad. You just have to learn the lingo the same way like you'd have to learn the lingo for computer programming. I mean, you know somebody who knows computer programming and they're talking to you about HTML and CSS, and if it's the first time you ever heard any of this stuff, you say, that sounds like it's rocket science. And then, oh my gosh, I have this repo and I'm doing a pull request, and you know, if you get scared every time you see a new big word, this is not the field for you. But if you get excited and say, I want to know what that word means, then this is the perfect field for you, because it's really not that hard. I mean, I do think, you know, it takes patience, it takes a lot of time, but ultimately I think just about anybody can get a hang of it.
Thanks so much. Appreciate it.
Yeah. Anybody else?
What are you going to do at Penn State anyway? What are you going to talk about?
I'm giving a speech with Milo Yiannopoulos.
Yeah, I heard about that, but it's just a speech?
I'm just going to make fun of him the whole time, I think. It's going to be good.
All right.
All right, guys. Yeah.
For the FDA graft drug looking for FDA approval without a trial, what was it? It's already approved in Europe or something? What's the backstory?
I don't think it's approved in Europe. I think it's just this like weird company that's just trying to fleece the FDA and get approval because it's a biotech generated graft. They're getting regulated as a drug, which is like very odd. And I think the rubber is going to hit the road where it's like, it's either not going to sell at all, or simply put, it's just going to get dinged by the FDA. So either way,
they bypass phase 1, 2, 3.
Oh, they did. They did.
They did it. Oh, I thought you said there were no trials.
Remember, phase 1 in the drug world is pharmacokinetics. There's no pharmacokinetics in a physical device, right? You just test it and see if it works. And they did a small trial. They did it compared to historical controls, which is crazy. And, you know, it's just a whole clusterfuck.
Oh, so this is a device? What is it, 501c? What do they call it?
Well, no, that's the thing. It should normally be the med tech
right.
development route, but it's a BLA. So.
Oh, geez.
Yeah, it's a very odd. They're calling it a cell therapy. So
I'll look into it. I'm not.
Yeah, we can talk for 4 hours about that one. All right, thanks, God. Everyone, have a great day. Thanks for listening.
Thanks, Martin.